Good morning, ladies and gentlemen. If you are thinking that you're in the right room, this is a meeting of the Leicestershire, Leicester and Rutland Health Overview and Scrutiny Committee. If you're not in the right room, bye-bye. If the public area chairs get full, we actually have set up, if extra people, we actually have set up the whole of the council chamber with a webcast. So in fact, all of the stuff that we're talking about will come up on the webcast. You can hear it. Can't join in, of course, but you can't join in here anyway. But at least it is available for people. If hordes more come through the door, there's room in there for another 80, 90 people. So hopefully that, if it isn't necessary, good. The other thing I'd like to say is that this meeting really was scheduled to start at 10 and finish 12:30. I would hope that we can keep to that timetable. However, if need be, if the discussions go on, actually this room has been booked until 4 o'clock this afternoon. But we would obviously have to stop for some sustenance. But I'm hoping we'll well be over by then. When it gets close to 12:30, 1 o'clock, perhaps have another little chat about what we think about it. I also like to remind everyone that this meeting is broadcast. And as I said, it's for those of you that want to go and sit in the council chamber, it's on in there as well. It's live on YouTube, and it also will be available on the archive after the meeting. Can I remind everybody that when they are speaking, to turn on the microphones, there's a big button at the bottom, red light comes on, and then after you've finished speaking, if you can turn it off as well, because the way it works, it can only cope with 2 people. And also to remind everybody to put their phones on silent, please, if you've got them with you. It does disrupt the meeting rather when we have various ringtones. Been informed of a couple of substitutes. Mrs. Janice Richards here is attending for Brenda Seaton, and David Bill is attending in place of Sarah Hill. So move on to the meeting in proper. This is the minutes of the previous meeting. I propose the minutes of the meeting held on the 10th of September are taken as read, confirmed and signed. Do we have agreement? Thank you very much. Okay. Oh, Michael, yes.
Thank you, Chair. So it's just a small item that I'm not down as attending the meeting when I remember it quite clearly.
Note taken. Declarations of interest. Do any members have any interest they wish to declare? No, thank you very much. Presentation of petitions. We actually have received a petition with, actually it's been, one of our officers has counted them, as they would do, of course, carefully, 367 signatures. And it's relation to item 6, the acute and maternity reconfiguration. So we're going to consider that as part of that item. We're not going to make it as a separate item. Question time. I've not received any specific questions from the public. Urgent items. I've not received any or been told of any urgent items. So we move on to item 6, which is the acute and maternity configuration, which is on pages 13 to 18, plus the supplementary appendix, of course. I must emphasise this agenda item solely regards the proposals for how the public consultation on the £450 million investment in Leicester's hospitals will be carried out. There'll be further opportunities as time goes by to scrutinise the substantive proposals for how the money will be spent and to respond to the consultation at later meetings. So to present this item, we have John Edler, I'm delighted to see, University Hospitals, and indeed we've got Andy Williams here as well, Chief Executive, Leicester City, West Leicestershire and East Leicestershire CCGs. So over to you.
Thank you very much, Chair, and good morning, everybody. It's nice to see many people again. So it's a great pleasure, genuinely, to be here this morning to kick off discussions about our proposed approach to consultation on the really major investment plans that we have in Leicester's hospitals. Of course, the principal reason why it's a great pleasure is that this is a really key stage in what has been a very, very long journey. I won't attempt to sort of estimate when it started, but it's certainly a long time ago. And as everybody who's been in this patch for a while knows, there have been some false starts over the years, or even over the decades. It was an incredible pleasure, and indeed, actually, if I was to be candid about it, surprise, to receive the announcement back in September from the government that it was allocating £450 million to the redevelopment of Leicester's hospitals, which, just to be clear, is the sum that we had asked for. So the scheme is fully funded. There's no requirement to cut any corners or make adjustments that don't make sense in order to fit in within a financial envelope. And I think it's very important for people to be aware of that. We had, of course, been, if you like, campaigning for quite a long time to try and make progress, but actually that progress had been all too slow, as I think everybody is aware. And that's why now, after all that waiting, we are really determined to press on as rapidly as possible, whilst, of course, meeting our obligations, particularly in this context, to consult with the public. And I won't dwell on that particular aspect because Andy's going to talk about that in a bit more detail, because, as you said, Chair, that is the focus of this morning's discussions. Having said that, I think probably pretty much everybody in the room is aware that the focus of our plans is around what can be summarised as clinical and financial sustainability. I emphasise clinical because as we currently stand, Leicester, and I re-researched this fairly recently, is unique in having the type of acute hospital configuration in this country that we do, and it's not unique in a good way. We are spread much too thinly across 3 full-blown acute sites, and we need to consolidate the way that we work in order to make our services clinically sustainable and work better for the population that we serve. In addition, we have been, and equally importantly, we have been significantly underinvested, whilst many hospitals were rebuilt over the last sort of 10 or 15 years or built from scratch. Leicester essentially missed out on that scale of investment, and so we're very much playing catch-up in the Leicestershire and Rutland patch. And we're already under construction with some of the developments that were given the go-ahead a couple of years previously, and soon, as a result of that, we will have a bigger intensive care unit at the Glenfield. We'll have more wards at the Glenfield, and we're refurbishing a whole series of wards as we speak at the Royal Infirmary. So you can really see things happening. And as you've got an item for information later on in your agenda, we're under construction of the new congenital heart unit as well at the Royal Infirmary, which now turns out to be the location of that, dare I say it, a very good call, because now it will be the first phase of the full-blown children's hospital in the Kensington building, which we now have funding for as part of the £450 million. So I won't dwell any more on the substance of the scheme. Obviously, we'll have much more opportunity to talk about that and all the issues that arise from those plans. Just to bring you up to date, if I might share very briefly about the stage we are at of the formal approval process. Clearly, we're talking about investing a great deal of public money here, and it's important that therefore that the programme and the projects within that programme are managed to the highest standard. They're therefore subject to a rigorous approvals process, which is run by a body now called NHS England and Improvement. That is the national body that oversees the NHS, sitting underneath the Department of Health and Social Care. So they're the people that we deal with at a regional national level on a day-to-day basis. This week we had what is called the Regional Assurance Panel, chaired by Dale Bywater, the regional director. That's the next stage of the process. I'm pleased to say that meeting was very positive. And we expect to proceed to the first stage of the national technical approval process shortly. So obviously I can't guarantee the outcome of those national stages, but so far so good. And as we sit here today, we do expect to be in a position to go out to public consultation in April, as outlined in the papers. So we're on track for the timetable that we set. Probably the only other thing to say before handing over to Andy, and Andy might want to elaborate on this because it's very much part of his responsibilities as the Chief Exec of the CCGs and the lead for the Sustainability and Transformation Partnership, which I'll big umbrella. We, of course, are working on the plans within the acute sector, within the hospital sector, in the context of whole system planning. And I would just like to, and we'll no doubt come to this in discussion, but I would just like to assure the committee that everything that we're doing is very hardwired together, for example, in terms of planning bed capacity and so on. And we anticipate that by the time we go out to consultation, we will be in a position to publish the long-term plan, or our local response to the long-term plan, noting that the long-term plan itself is a national document which is already in the public domain and has been for some time. Thank you very much. Obviously happy to take questions as we go.
Okay, thank you. Good morning. Far fewer people will know me than John, I'm sure. So for those of you I haven't yet met, my name's Andy Williams. I've recently started, I'm just coming to the end of my second month as the Joint Chief Exec across the 3 CCGs in LLR. The clinical commissioning groups have a number of responsibilities, but particularly in the context of the discussion this morning, the legal duty to consult under the Health Act falls upon CCGs. So the consultation leadership is with us, and it's our obligation in partnership with our colleagues to ensure that there's a proper process for public consultation. The agenda item this morning, as you quite rightly said, Chair, is not about the substance of the changes that we will eventually consult upon. It's actually about the process of consultation itself. That responsibility lies with us, but we're very keen, I think, to try and make sure that we get that right. And testing it with you and getting your views as a committee and individually as councillors and leaders in the system is one of the ways we hope we'll make sure we end up with a very effective consultation process. I'm going to talk just briefly through the structure of the paper, and then I'll leave plenty of time for questions and discussion, because I suspect that's what colleagues would prefer. So you have a proposed consultation paper in front of you. And just running through that, I think starting with the introduction, it reiterates the purpose of what we're trying to do and how the paper's been produced. The background, I think, has been very well described by John. At section 3, we describe the purpose of the consultation, and particularly the governance and the legal requirements that underpin it. And I guess the only thing I'd want to emphasise there is that we are trying very hard through this process to make this an exemplar process. We want this to be a really genuine consultation. We want to use this opportunity to hear as wide and as representative a range of views as we possibly can from the whole community, and we'll reflect that in the kind of detail of the plans going forward. Section 4 describes the consultation activities, and I guess the thing that I would want to emphasise there is that it's a multi-activity basis, so we're using a whole different variety of media, we're using a different variety of venues, we're working in different ways with different segments of the population, all of which is designed to give us the very broadest possibility of reaching out to different communities and different parts of the population in LLR, and you can see that we've been particularly mindful there of the kind of protected characteristics that define the population that we're keen to hear from. We go on then in the document at section 5 to describe the content of the consultation document. And it's important, I think, to be clear here that we will eventually be consulting on very specific proposals around the configuration of acute and maternity services, but we have an ongoing process of discussion generally about our approach to the development of health and care, and this forms part of that process. There's always a slight artificiality in breaking up consultations to talk about hospitals, to talk about community, to talk about primary care, because people naturally say, well, in order to answer this question, I need to understand what you're doing with these other things. We're really committed to having a broad conversation, and at the point, as John was saying, we go out to consultation, we expect to have those other things available as well. But notwithstanding that, we do believe this consultation is important in its own right. So we're very keen to make sure that we have a focused discussion about these issues as well. 6 confirms what we'll be consulting upon, which follows the input you've heard from from John, and then section 7 describes what we do with the consultation and how that works. We always ensure through our processes that we have a degree of independence about not just the way the consultation is conducted, but the way it's interpreted. And it's important to us that we get as clear and candid and comprehensive a response as we can. So we're very ambitious about this consultation. We want it to be meaningful and to be best practice, and we hope that your input today will help us to get it into that place. I'll pause there, Chair. I'm very happy to, with colleagues, to take any questions. Thank you.
Thank you very much, John and Andy. So, people want to make any points? Join in discussion? Michael, yeah, start with you.
Thank you, Chair. It's kind of just to pick up on a point that Andy's made, and something that I know myself and colleagues at Healthwatch Rutland have made at different meetings about that. Okay, the fact that the consultation itself has to happen as an entity, but how that interconnectivity to everything else that's happening, and whilst if you are being forced, because it seems like you're mandated to make sure the consultation's happening as they are, but there is a part of that just sets the understanding of how it all is linked together, because I can't overstate how important it is for people to be able to kind of make that informed input to the consultation, understanding what's happening with the community services, what's happening with primary care networks, what's happening with the with Leicestershire Partnership Trust sites, with mental health and the community hospitals as well.
No.
So thank you. I think it's a really well-made point, and it's always difficult because at any given point there's always work in progress, isn't there? So I think what we've tried to do locally, and I'm talking a little bit here on behalf of the organisations because of course I personally wasn't here when some of this was happening, but I know there's been a very wide engagement about the overall strategy within this area. We've got a very clear and pretty straightforward strategic approach actually, which is to effectively focus relatively more on primary community and preventative services and relatively less on hospital and acute services. We've got a commitment to deliver, and we have so far delivered parity of esteem in our investments in mental health services, and later on the agenda there's a substantial item on the development of mental health services. So these changes are set in the context of an overall strategic plan that talks about slightly rebalancing the system in favour of those things. A little later on this agenda, we've also got an item about our response to the long-term plan, and that describes some of the investments and plans that we're making. But the strategic intent, I think, is pretty clearly articulated, I would believe so. And I think for the reasons that John described, the aspiration to redevelop acute and maternity services through a major capital redevelopment has been a long-standing part of that plan, actually. And so whilst it's always important to continue to update and keep that dialogue going, it does seem to me that this fits very strongly into a strategic direction of travel that we have engaged with and continue to engage with very strongly with the population as a whole. So certainly that's how we see it, and I'd be interested to get other colleagues' views on the extent to which that feels that way to them too.
Morning. I'm delighted to hear the words that you're saying about an ambitious, meaningful, best practice consultation on this stuff. And yet when I was reading the documents, what struck me was when we were talking about the extensive engagement we'd undertaken since 2015 about maternity services. Now, I think I'm pretty engaged in that agenda. I also happen to have had 2 children since 2015 and don't feel engaged, let alone extensively. I don't believe at any point during that journey either time I've been consulted on this stuff. And so I guess the challenge I'm finding is that whilst the words, the actual lived experience, perhaps there's a mismatch between the two. And I speak as somebody who's pretty engaged in this agenda.
So thank you, and your experience is your experience, isn't it? So I absolutely accept it on face value. I think one of the things we constantly try and do is to reflect on the way in which we've been able to reach certain groups of people or not. And that's led us in these proposals, I think, to use an even broader range of media, an even broader range of approaches. I guess the obvious kind of question to you would be, given your personal and highly relevant experience, what do you think we might have done differently? What do you have a particular view about how we could counter that in terms of changing or embellishing this plan? Because genuinely we would be very happy to do that if you think we've missed a trick or just an entire place perhaps, or a group of people. So if you have a view on that, I'd be really happy to hear it.
I guess the challenge is straight back at you. Really, is if you're failing to engage through this extensive consultation and engagement, somebody like myself, twice, because I've had 2 children during that period. Who else are we missing? There will be an awful lot of people who are less engaged, have moved to houses I've not, could have written to me. You could have phoned. I've not changed my phone number or my address. I've not missed a midwifery appointment, and yet at no point in that process has anybody, I don't feel, reached out to me. But they would have been very obvious, easy ways to reach out to some quite low-hanging fruit. So if we're missing, not just me, but people like me, other friends who are having children at our hospitals around the same sort of time, we're missing an awful lot of people. That's the problem here.
Yeah. Okay. So thank you very much, and we'll reflect directly on that and think about how we can make better use of our existing relationships with people and public as they use our services through this consultation process. I hear that, and we'll go away and reflect and think about how we can refine and improve the plan in the light of that feedback.
No.
Thank you for bringing that, Chair. I know I wasn't the first, but no, I'm sorry, there was a point specifically about that. Yeah.
I'm quite happy to let my colleague say his bit on maternity, and then if I could then say my bit after, that's fine with me, if you're happy with that. Yeah.
Thank you, Chair. It's really just to let Councillor Marsh know about some work that we've done with the maternity, what's called the Maternity Voices panel, and it's something that we did in support of the Better Care Together maternity kind of group. We actually recruited a number of new mothers and actually brought them together on a regular basis, meeting with members of the maternity board to talk very much about their experiences of services. It was something that was kind of at the time, kind of a bit of a reach out. It wasn't a substantive engagement programme per se, but certainly just wanted to kind of let you know about at least something we'd been involved with very much around maternity and engaging with new mothers and their experiences of services.
Thank you. There's nothing like 2 small children to make you feel like an increasingly ageing mother. But I think I'd be keen to find out more about it. I guess the question is, continues to be, if this is what we consider to be extensive engagement on that small issue, how are we going to change what we do so that it really is ambitious and meaningful and best practice elsewhere, when we've got a much broader and certainly in areas of the city, very at times very vulnerable people who are accessing this and who are not engaged at all in the kind of levels and this kind of rhetoric and the narrative and the wording that we're using already. Yeah, thank you.
I've while you've been,
I would just, if I might, Chair, interestingly, Councillor March's comments have just caused me to have a read through. If you look at section 4 about of the paper that Andy was just taking us through on consultation activities, actually, it doesn't say very much about actually interacting with patients actually using our services. It does. There is reference to patient representatives and patient groups, but it does occur to me, and this might be an explanation for Councillor Marsh's experience, that that's not quite the same. If I might sort of paraphrase it a bit, as when patients actually come to clinic or come for a scan or whatever it might be, sort of saying, oh, by the way, this is happening, this is how you can get involved. I actually don't think we've done that much of that, and actually that kind of thing isn't indicated actually in our proposal. So I think there is a whole theme there, not just around maternity. Maternity is a particularly good one because, of course, by and large, the women going through our maternity services are actually well. When people are obviously ill, they have other things to think about. Do you see what I mean? So there are complexities about engagement in a live kind of patient situation, but it's certainly not impossible. So I think we should take that away as a particular theme. It's just a thought. You were asking for some specific things that we might do, and I think that occurs to me that is one thing we. But not just around maternity, but around the proposals as a whole. We need to do more around interacting with patients who are going through our services now. Does that make sense?
Yes.
So I think point taken is how it's done.
Just to say that it has been stimulating my mind to think of other ways. And when you mentioned about having 2 children, I've had 3, but a certain longer time apart. But I do particularly remember on the odd occasion I actually used to go with my wife to the antenatal clinic. There's an obvious place for to start telling people. In my own village, our church operates on a Monday a mums and babies group, which sounds fine. There's 30 to 40 people appear every week, and of course because it's mums and young babies up to 6 months, it changes. And I kept thinking, oh, it'll last for a few weeks. This has been going on for years, and every month another bunch arrive. It's brilliant. So there are other avenues, I would say, really, where we could probably push. But particularly, you're right about actually existing patients, people in outpatients, all sorts of places, aren't there? Yeah.
Thank you. It's going back to John's point, actually, that you made at the beginning, and Michael picked up on, and I just wanted clarification on it, because you talked about whole system planning hardwired together and the National Technical Appraisals Panel. And really, do they take into account all the service changes that are taking place? Because I think that is a vital point and really important, and that's what I want to do. Is that panel taking that into account and addressing everything?
Okay, so yes, but I think would be the answer. So let me just explain that. When you take a complex proposal like this one through an assurance process, there's normally a whole series of ways in which it's evaluated. They include the kind of integrity of it as a proposal in its own right. So do the numbers add up? Do the sequencing of the builds add up? Do the kind of operational plans add up? But they also look at it in the context of, does it fit with the wider system aspiration? So we've explicitly had to talk and demonstrate that it's consistent with the strategy as a whole for this area, that it relates and fits with our existing plans or our future potential plans for the development of other service areas, and that it fits into an overall sense of how we're going to be allocating resources broadly across the different programs, acute, mental health, children, whatever have you. So we have to provide evidence on all of those things. The reason I said but is that these things there's a constant dynamism. So every month, every year, the challenges that we face as a health service move and evolve and change and develop. And those policy imperatives, and we work to a national policy agenda often, those things aren't always perfectly sequenced. So we've just, literally just in the last few weeks, for example, we've had some further emphasis and clarity on investments in mental health. So it never stands still. And as a consequence, we've always got the challenge, I think, of trying to talk about how we plan in context without getting stuck into a situation where we can't do anything because we can't describe everything. So we have to work with the plans we've got now. We have to do our absolute best to show that it all fits together coherently. But we absolutely also understand that, you know, 6 months from now, a year from now, there may be another change in cancer treatment, there might be a new drug, there might be a new policy imperative around a different aspect of service. And so we can't say, well, for the next 10 years, we're not going to change anything, or we're not going to consult on anything until we've got absolutely everything lined up, because we'd never actually get to the point where we could begin to move forward. So we try to get that balance right. We try to make sure that it fits into the grand scheme of things, but we recognise that those things are dynamic as well. And so there's a practicality to it as well as an intent. I hope I've kind of conveyed that clearly.
You have, but the reassurance is how do you feed that constant change into the overall picture that we're facing here in Leicester, Leicestershire and Rutland?
Okay. I think the way that we try to do that is by having a very clear strategic intent. And so the thing which hasn't changed for some years here actually, and won't change going forward, is the sense that the correct way to deliver really great health and care on an ongoing basis is to focus relatively more than we have in the past on primary, community and preventative services and our relationship with councils, with social care, with the voluntary sector, and to focus relatively less than we've historically focused on the provision of secondary care, hospital services and out-of-area services. That gives us the kind of strategic framework within which we operate. And it's that framework which is a more constant thing going forward. These proposals, as they will eventually stand when you come to see them in detail when we come to that point in the consultation, and will be absolutely consistent with that kind of strategic intent. So, you know, that's how we kind of try to provide a degree of continuity going forward.
If I might just add to that, Chair, the only thing I was going to add to what Andy said was that in practical terms, what that means is, I think many of us have heard of the pre-consultation business case, which is the very large technical document which has to be approved by the centre. The process that I was talking about in my introductory remarks is essentially about the approval of the pre-consultation business case. That has to be approved at national level in order to start the consultation. I can't remember, sorry if I said this before, the final version of the pre-consultation, the approved pre-consultation will be published prior to the start of the consultation process. Now, many people have been asking for that for a long time, but the point relevant to the question that you asked is that has been extensively updated in the light of the publication of the National Long-Term Plan and the progress with local plans and implementation. Probably the most significant of the latter, it's not the only one at all, but one of the most significant of the latter is the implementation which has just happened or just begun of the first phase of the community services redesign, which is actually executing many of the improvements in integration of services, including with social care, that people have been asking for, and it's been quite a long time in coming and is now being implemented. So clearly we've now that from the point of view of these proposals is entirely beneficial. It's a really positive thing. There will be a second phase of the community services redesign coming up, and that will be progressing over the period, and we will constantly be iterating. But just to assure you that the PCBC has been brought up to date for all the latest position, the latest activity levels, all the latest financial assumptions, all of that kind of thing.
Thanks very much. Amanda. All right, Janet, then. Between you.
Thank you. My comments are very much, for anybody who doesn't know me, I'm the chair of Health Watch Rutland, so my comments are very much reflective of what we're picking up in the Rutland population. And it really refers as well to the comments Michael first brought up, and also to your comments, John, is that the PCBC instructions from NHS England are particularly that any clinical codependencies must be recognised and must be consulted upon. Our concern in Rutland is that, excuse me, the consultation for the reconfiguration is going to be in April, but we're not going to know the outcome of phase 2 of the community services redesign which includes the future services and the future buildings of Rutland Memorial Hospital, to which the Rutland population have a great emotional attachment. I'm asking if possibly you could tell us how you can bring an unknown quantity of the community services redesign phase 2 into your consultation, so that the Rutland people can make an informed comment when you consult on the reconfiguration in advance of the community service redesign phase 2.
So we're well aware, of course. Andy will no doubt want to comment on this as well. But so I'll just come at it from the point of view: what do any of those kinds of changes imply for the acute hospital side of things? And it really goes back to the themes that I was talking about before. We have a unified capacity planning model. So if we think about just about bed capacity, it's not obviously just about bed capacity, because it's alternatives as well, and looking after people more in their own homes as a first preference, and so on, which is what the vast majority of people tell us they would prefer for understandable reasons. All of that it goes into effectively one bed model, what we're doing in the acute sector and what we're doing in the community, and therefore at any time those can be adjusted to be kept in synchronisation. So at the moment, our acute bed planning, which is obviously contained in the plans around reconfiguration, assumes, if you like, what we currently know about about the situation with community services. If something different happens with community services, which has an implication for acute capacity, we can then adjust the acute capacity. But I have to say, I think that's very unlikely. That's not really what is happening. It's more about the balance between home-based care and institutionally based care in the community hospitals is what the community service is really designed about. And that's a different cohort of patients. It has to be kept connected, I don't deny that at all, but it isn't quite as critically dependent. There isn't certainly not enough to say we can't carry on with this side of things whilst we await the final outcome of the second phase of community services redesign. That simply isn't necessary, and of course would be very costly if we did do that.
I respect what you're saying, John, and I respect that you're obviously very keen to go on ahead with your reconfiguration consultation, etc., etc. What I'm trying to make the point of is that what you plan is very dependent on, there's an interdependence, and the people of Rutland really do want to know what's happening in the whole and not just in the piece of the reconfiguration. I'm asking if you have thought of, or if you can actually come out to the Rutland people and say, and this is what is very likely to happen with community services. Either you'll have lots more outpatient appointments, or you've got to travel further if you're outpatients, and all the other clinical interdependencies that are implied with your reconfiguration, the long-term plan and the community services redesign.
Yes, thank you. And you'll know, because we've met, even though I've been here a relatively brief time, and I'm really committed, and we are, as a system, really committed to having exactly that conversation with people in Rutland, actually just generally everywhere, but particularly I know how important it is in the context of Rutland. The important thing here is that we don't wait for perfection to become the evil of good. We know that this is going to continue to be an ongoing discussion, but there are plans that we're developing. I know you're actively involved in that. The council in Rutland are working on it. We're working with it to have exactly those conversations. So there will be a very active process of engagement and discussion. I think what these plans give us is a kind of a clear sense of how we can best organise and deliver acute hospital services. That gives us a place against which we can then plan what's the correct service delivery option for Rutland as a place and for the other places, and we can start to work on that in detail. I don't see those things as incompatible, but I absolutely understand how important people feel that other conversation is, so we absolutely will have and are committed to keeping that kind of conversation going and to bring some agreement to those things
we can be assured that that conversation about potential changes with the community hospitals and facilities is brought into some way into your consultation. That would be what Rutland people would really, really appreciate.
So to be clear, and so that there isn't a misunderstanding, I think we're really committed to running those processes in the same sort of time frame. I think it would be wrong to create a sequencing that meant that we couldn't progress any discussion about aspects or indeed these proposals until we'd resolved every single one of those issues through a formal consultation. I don't think these are sequential steps. I think they're parallel processes, and we need in everyone's interest and in the wider interest to progress these, I think, very good proposals for the development of services, and engage in a very active conversation about the acute and maternity configuration. At the same time, and just as importantly, we need to be having a very active conversation about all the other aspects of care in Rutland, particularly, of course, the acute and community and primary care services. But I'm really frightened, if I'm honest, or nervous about creating something that looks like a kind of stepwise approach, because I think what that will do is it'll get us locked into a place where we can't move anything forward, and then I think we're all going to get very kind of frustrated and anxious, really. And so what I want to say is absolutely hear it and we'll respond to it positively, but that shouldn't prevent us from also having a very active engagement with people about these specific proposals as well. We need to do both and, not either or one first and then the other. Otherwise it'll slow everything down, and we'll all, be worse off as a consequence.
Thank you. I can see the point that you're making, and I value that you've taken on the point I'm making, and hopefully we can work through it together. Yeah.
I think that's really quite important, the fact that this is not a step mode, it is parallel. But point being, it's important that any of these engagements with the public that you've got in this long list in section 4, people at those need to be aware that there will be questions, particularly obviously in Rutland's case, about the community service review. So it's just to be aware of that thing.
I think having been involved in this sort of scrutiny process for a little while with the changes as proposed, I think the paper probably, in my view, doesn't really address the enormity of what is being put forward. I think it underplays it a little bit. And what I mean by that is the information presented in the paper doesn't, to me, present enough data, the weight in the, and I'll just give a couple of examples. We talk about in this particular paper about the consultation to close Melton midwifery service. We identify how many babies are born a year, we identify how many babies are born at Melton, but actually that's it. There's no real sort of what's the patient experience. We know that the Melton services is always comes up with excellent CQC. How do we maintain quality? And it feels a little bit like the data is too flat. There's not enough there that builds the picture. The second part is about the beds, and clearly, restructuring the hospital and the 3 sites and the way that it's been presented, one of the clear problem that the public will probably feel is actually how does the bed structure change over time? What reassurance do you give to the public? Because consultation has been difficult, and having been again in this process for a little while, the reluctance to consult in a particular way has been a feature of some of these meetings over a period of time. And on page 16 it references the amount of beds that are required, how many required in the new, there were different numbers in the SDP, and actually the difficulty for us as scrutineers, but also for the public to see, is what impact does that have on service over a period of time. And while I appreciate what Councillor Felton was saying in terms of step approach, I actually think that the public has to trust the process. They have to be confident that the consultation is valid and what they're saying is listened to and is important to them. And actually I think us as councillors representing them need that as well. And at the moment this paper to me feels a little bit one-dimensional. There's not enough data in there. There's not enough in there that gives me the confidence that the consultation and the way that the public are going to be consulted with, they're going to feel that they've been listened to. And that is just sort of my overall feel on that.
So one of I mean, these things justify the fact that we're here having these conversations, because that kind of feedback is exactly the kind of thing that we need to help us make sure that when we come out to consult on the process, bearing in mind we're not today, we're consulting on the process of consultation, you know, when we come out and start the consultation, that kind of feedback, understanding those sorts of things will enable us, I think, to further refine and think about the messages. It is a slightly strange conversation today because we're talking about a plan for a plan, aren't we? We're talking about how we will talk to people, not the specifics of what we're saying. But the fact that you've been able to offer those thoughts, and your colleague did, about the way we might access existing service users, both of those things straight away, parallel conversation, all of those things are adding value ultimately to the way we will approach the consultation. So again, thank you. I've heard that message. We'll think very carefully about how we talk to people about the basis of modelling, the sequencing. There are, of course, very detailed plans about that, but understanding that we'll need to go through those with people and explain it, I think, is helpful. So we'll make sure that that's reflected in our approach to consultation. Thank you.
Thank you, Chair. I wondered if I might just take the opportunity on the back of the reference to bed capacity just to explain. I personally, I do take the point that we've always, with the consultation document, we're always in a bit of a tricky place, as you might imagine, because if we write screeds of technical stuff, we'll be rightly accused of doing something which is not very accessible to anybody who doesn't make a living out of doing this kind of thing. On the other hand, if we go too high level, as you understand, say, Councillor Hack, we don't have the we don't necessarily have the detail to scrutinise it. We know from the previous engagement activity that two of the key issues that came out of that are bed capacity planning, bed numbers, paraphrased as, will there be enough beds when all of this is done? Another one is transport and access issues. So I was wondering whether, so one approach that we could take, rather than expand the base document, we could perhaps have, and there might be more than one example of this, but we could perhaps have sort of what you might call supplementary documents. Now, clearly the PCBC will be in the public domain, but not many people will have the time to read the 1,500 odd pages of the PCBC, and neither should they be sort of made to do so. So what we could do maybe is some sort of supplementary briefing notes, which, for example, just as an example, could say a bit more about how we've worked out what our bed numbers are. Now, we've got the basis of that already, because I think it was Mark who came to Scrutiny and with colleagues, and was it you that did that? I can't remember. Yeah. But we've had discussions about bed capacity planning here. I wasn't actually at that session. But that's another idea coming out of this discussion. That's why Andy's saying what he's saying. These are all great things that we can think about. But to my mind, that would be the obvious thing to do to get that extra level of information. And any thoughts that members of the committee have about particular areas that would benefit from that. Sort of topics that we could expand without making the consultation document itself a great big thing, might be a way to go. Yeah, would be welcome.
If I just come back on that, I think the reason why, I mean, bed capacity is something that people feel publicly they feel connected to it, and actually reduction in numbers makes people feel a little bit nervous that there's not going to be enough space, but actually makes me nervous as a councillor, because, you know, having seen the winter report from, not winter gone, the winter before, we know capacity was a problem over Christmas because it was an issue in the run-up to Christmas. So we were at really full levels, the hospitals were full, which created lots of pressure in the system. So it is something that people feel personally connected to, and I think showing that the numbers and the numbers that are put in the public domain, we keep changing our minds on it, and we have to create trust the SCP did report a different number. We're reporting 2 numbers in here. We know what the current numbers are. And I think that there is this, we have to generate trust, and that's a really important part of the process.
Absolutely, and believe me, as somebody who has to deal day in day out with the consequences of where we are now, I absolutely am on the same page as you there. Indeed, we absolutely have to get the bed capacity planning across the whole system right. On the acute side, just to be clear, I think actually the phraseology of the consultation document at the moment is slightly potentially confusing. The current plan is that the total beds that we have will increase by 139 from where we are here today. So there definitely isn't a reduction in beds, there is an increase. That is a very different plan from the one that we had maybe 3 or 4 years ago, which I think from memory was reducing beds by around about 400 overall, actually from a lower base, so significantly lower base than we currently have, because we've been expanding bed capacity. The reason for those changes is demographic trends, and also it has to be said, and I don't think there's any secret about this, something of a change in the national approach to this. Just picking up what Andy, just being as concise as possible about this, just picking up what Andy said. Andy used the word focus on community and primary care and mental health, not switching resources as such. And I think his phraseology, if I might say so, was probably quite deliberate, because in the past, the rhetoric has tended to be, if we simply do more in the community and bolster primary care and so on and so on, we will need significantly less capacity in the acute sector. That is no longer the national line. It's Simon Stevens, the national chief executive, and ministers and so on have all said things recently along these lines, that we definitely do need to bolster primary care, mental health, community services, and so on, and prioritise investment in those areas, which is exactly the national plan and the local plan. But that does not mean that you could have a smaller acute sector as such, because there's simply too much demand out there. But it is the way of keeping the whole system sustainable. Hence, our current plans actually slightly expand the sector. Now, having the acute sector. Having said that, we are. I don't think I'm talking out of school here. I mentioned about the assurance panel, the regional assurance panel that we went to earlier this week. One of the principal focuses of discussion was, how robust is your bed capacity planning? Is it the right number of beds? No, let me put it more bluntly, is it enough beds? Not, oh, we think you've got too many beds, you could do with less than those, let's save a bit of money, or any kind of conversations like that. It wasn't like that. So we will continue to refine our bed capacity plans. This is very much a national focus now as well. So we're completely in tune with the sort of national mood music. Obviously, by the time we go to consultation, we will finalise those plans for the purposes of consultation. I certainly can tell you that the proposals won't be less than in the version that you see now. But in terms, sorry to waffle on a bit, but it's such an important issue both to the public and stakeholders, and indeed to ourselves. It's probably worth spending a little bit of time on. We are absolutely determined to get bed numbers right in these plans. Paraphrasing what I've said internally to my people, we are not going to spend £450 million and still not have enough beds. Simple as that.
That's reassuring. Gail.
Thank you very much, Chairman. Can I start by saying that I found this document far easier to read than many others I've seen from you all in the past. It was much clearer, so well done. That's a tick. However, I do think it would be helpful if you thought a little bit about reordering what you are saying to people, so that there is not a thread running through, there is that, but there's a clear path. So what's the problem? How have you addressed it? And here's how you're going to deal with it. Because it does jump about a bit as you go through. So I think it could be a better, clearer road, if you like. So that's my first comment. My second is, in one or two places, it does look a bit like you've made up some decisions going forward that rather negates consultation. So, for example, you talk about the number of mothers who've chosen to go outside the area to have their babies. You haven't said why this might be. And the implication is it's because the hospital at Melton isn't good enough or whatever. You know, it's something to do with the way you configure your services. Well, as an anecdote, I'm going to do an anecdote, sorry, Chairman. My next door neighbour changed last week. I've got a new next door neighbour at home. And I was talking to the lady of the house a couple of nights ago, and she has an ongoing health problem, and she was asking about GPs and so on. And she said, and when I need to go to the hospital, I go to Peterborough, don't I, from here? Well, the reason for that is because you would go to Peterborough from where I live, because it's a darn sight easier to get to than Leicester, and is actually slightly nearer as well. So people might have chosen to have their babies outside of Leicester, Leicestershire and Rutland simply because the maternity hospital they go to is nearer to home, easier to get to, etc. But there's no hint of that in there. The implication is that it's to do with the facility. So I think that needs to go. And similarly, you're talking about having a midwife-led unit at the General. But the way it's written is we're only going to have it for a year, because after a year it won't be very popular and we're going to close it down and we'll go have it all centred on the Royal. So you've got to think about the way you're wording some of these things and what's the implication behind them. And while I'm talking about the General, I think you might have missed a trick. You are actually asking people what other services they might want to see there, which could, you know, help inform you going forward. As going back to what Councillor Marsha's saying, yeah, your own staff are going to be your best way of communicating. But believe me, your staff handing a leaflet to their patients is not the way to do it, which is what it tends to be. And I mean, I've been given over many, many years of involvement with a hospital leaflets which have gone straight in the bin. And they've gone straight in the bin not because I don't want to read them, but because they're in a format I literally cannot see because of my sight disability. So you need your staff to talk to their patients, to say, we've got this going on, this is the implication for you, do you want to get engaged in the process? And particularly the key areas that are going to impact, like maternity, I mean the really seriously key areas. So I would urge you to do that. Where you are using I'm really in the nitty-gritty here, where you are using electronic communication and you've put in your leaflets, you can find out more at X. Put the actual web address, not the generic one, because there's nothing more frustrating for somebody who A, hasn't got time, or B, doesn't like using computers particularly, to put in a web address and then get to the home page. They want to get to the bit they want to get to. And there are people I know who can't navigate beyond the home page anyway, so you'll never get it. In terms of your supplementary documents, whether you write them this way or just think about them this way, I mean, I think it's a brilliant idea, by the way. Think about them in terms of frequently asked questions. You know, what is it that the person actually is going to ask, who actually wants to know, rather than the academic treatise approach, for want of a better expression. And I think finally for this point in time, because you've heard enough from me, it's the issue of travel. I was very distressed to read the travel bit in this document, because I don't live in Leicester, so a shuttle bus between the sites isn't a lot of help to me because I can't get to Leicester in the first place. So when you're talking about travel, acknowledge that for many people, unless they have their own mode of transport, unless they have a car, they can't easily get into Leicester anyway. So whether something's at the General or the Royal is neither here nor there. And so if you're going to talk about it in reality for those who are in the more remote parts. And public transport for most of us who live outside the city is totally dependent on the local authorities subsidising of said transport, and that subsidy will only last as long as our budgets allow. I'm getting nods from across the way. I'll stop there, thank you for now.
Thank you. Just to acknowledge what an incredibly helpful list of suggestions. Thank you very much. I'm not going to answer those. I think we heard and understood, I think, is the correct response to that. So that's very helpful. Thank you. Patrick.
Thank you very much, Chair. I still require substantial reassurance about this consultation process. I mean, for the benefit of people who don't sit on this committee, we received this paperwork less than 7 days ago. Yeah, and it does all rather feel rushed and half-baked in many aspects. And I'll go through what appears to be missing from this document, which is probably the areas of most concern. And you've helpfully highlighted them in yellow on it to say that this needs to be inserted. There is talk about the savings and the financial profiling, and it says insert link to financial plan on website, which I presume is the pre-consultation business case. It may be a digest of that. Then that's on page 12. On page 14, we have further information on bed modelling can be found, insert appropriate link to PCBC. Then we go on to page 29, and it says, the travel impact assessment can be viewed at insert website address. And then we get for detailed financial information can be viewed on our website, insert web address. I could go on, page 31, we have the review of the other options, visit insert link to website, and then on page 34, just saying because it's giving helpful notes, is the full detailed engagement available at an insert website, and this is right throughout the process, and this is the problem. It's the major problem I have with it, and it's a problem that can come as little surprise to you that the lack of the availability of the pre-consultation business case is at the heart of the problems with this consultation, and indeed you end up with on page 36 the consultation will run from XXXXX to XXXXX 20XX. Yeah. So there's kind of key things missing in here. I cannot give assurance around this process until I see these key missing parts of the consultation. It's a case of, I fully appreciate what you're saying about not taking community services sequentially, but many of the councillors around here will have had experience of similar processes when it comes to large-scale developers from private housing, who will say, well, what we'll do is we'll get the houses built and then we'll have the developer contributions. And funnily enough, we always get the housing, but the developer contributions never quite seem to be quite as parallel as it was first promised. Now, I appreciate the logistical difficulties of doing that sequentially, but I think we need a little bit more appreciation of the fact that the feeling is that this will be pushed through and community services will be a Cinderella part of it. And I think we've got to have clearer assurance that community services is not going to be the Cinderella to this particular project. It is a case of, I appreciate what John says, that all these numbers are very big and they may overwhelm our tiny little minds. But it is a case of, we saw with Carillion in Liverpool, nobody kept their eye on the numbers, which is why we've had Carillion in Liverpool. And indeed, if we go to more topical things, HS2, we have a report today that it was underestimated just how complex the project was. And therefore, I've worked with people on very complex projects, including really complex data. And actually, I believe in the wisdom of crowds. If you get that out there and people will take away their parts of it, they will spot things that you and me and anybody in this room will not spot. I appreciate NHSE and I, this great big white hole brain is taking this and digesting this. But as we've seen with HS2, it doesn't get everything right. I think the fundamental approach, which is we're doing the consultation to avoid the threat of judicial review, yeah, I'll be frank, we're in councils, yeah, that is always tends to be the officer approach. Actually, we should be asking, how is consultation going to mould these designs and make it a better scheme? So, Chair, I mean, we have another meeting on the 18th of March. I'd say there's parts of it and there's chunks of it which are absolutely fine. But what is missing is really the fatal holes at the heart of this plan. If I might go on to some of the specifics and the design issues, is again, I appreciate a lot of this will be online and there's a chance to expand. But it doesn't really look great when you ask somebody for a response and you give them a 1" by 6" box to fill in their response. Yeah, I appreciate that, but it's kind of not really taking the fact that people may have detailed comments. In relation to Leicester General, it does feel like spin when you describe everything that you will keep at Leicester General, but you do not describe what will be taken away. And I think we do need to have clarity, and people do need to be clear. We around this table may be all absolutely clear about what the impact on Leicester General is. However, if you're a patient going to Leicester General, I don't think you get really a sense of what's moving. And let's at least be honest about this. If there's the medical case for the withdrawal of services and the consolidation on the Royal Infirmary site and on the Glenfield site, and indeed there is a case and it's valid and some of us may debate it, let's at least get it out here rather than look like we've done some smoke and mirrors where we've said what's staying, what might actually be improved, but let's not talk about what's moving. I think we just need to level with people around that. I appreciate that we've got to get this process moving, but my fear is, and other people will be better versed in the medical impacts, the human impacts, because at the end of the day, we're not cohorts, we're people, and we move between the cohorts. But my particular area in other lives is I look at finances, yeah, and actually, even in a very dense document, it is amazing how quickly you get to where the problems are. And I'll give you a quick example that's in the document is this concept of 500 births, you know, it's like some sort of target that we've got to hit to keep the birthing unit. So clearly we'll have to tell people in Leicester to get reproducing in order that we can hit the target. But there's no kind of sense of why is that target? Why does that make sense? Is it a clinical sense? Is it a financial sense? Yeah. I mean, Chair, I appreciate this to get moving, and I don't wish to delay it any longer. But the whole idea, I would not wish for this committee to appear that it has given its reassurance about the whole of this consultation. You've said the processes are moving. You say that you're hopeful that Whitehall will produce a decision by the end of March, which is quite optimistic, but who knows? Miracles happen. But we do have a meeting on the 18th of March, and I would recommend, Chair, and I would ask it to be expressed as the opinions of the committee, that we thank officers of the National Health Service for this first step, that actually we have a report back to the 18th of March to actually see how these comments and ideas have been incorporated, because clearly this is a draft document. It is going to change, and I think we really do need one more bite of the cherry at the 18th of March. Clearly we're not going to be able to change things fundamentally, but we need another bite of the cherry at the 18th of March to feed in before this goes live.
So, thank you. There's a huge number of issues to pick up there, and I think I should respond. One of the difficulties that we always have as a National Health Service, particularly in our relationship with council scrutiny processes, is the point at which we begin the conversation with you. So at a point, we will have to go out to formal public consultation on the specific proposals that we will have agreed through the signing off of the pre-consultation business case. We are not at that point, and we could have delayed coming to talk to you until we were, in which case you wouldn't have had a document with yellow lines in, you'd have had the facts. But for the reasons you've described, John's described, we're not at that point. What we didn't want to do was to wait until we were. So it's absolutely right. Why would you agree a document that says to be agreed? And the reason we're here at this stage, when we've still got yellow boxes and not numbers, is because we're talking to you at the very earliest opportunity, we believe, whilst there's still a chance to shape and change and influence the actual process and structure and organisation of the consultation. So I think it's important, with the greatest respect, not to confuse the two issues, the how are we planning to talk to people issue with the detail of what we're going to say issue. Because I absolutely accept that we haven't even attempted today to bring to you a specific set of proposals as part of a formal consultation about whether we should be changing something or not. That will come in time. What we're trying to do, I think, here today is say to you, this is how we intend to have that conversation when we're ready to. And we're nearly ready to, but we're not quite there yet. Having said that, I absolutely take the point, and I agree very strongly with you, actually. I don't think we see this consultation process as a defensive way of avoiding getting into trouble procedurally. I think we see it as a really great opportunity to genuinely engage everybody, as many people as we can, in the detail and the thinking behind what we're planning to do. And I absolutely agree that those processes, when we do that, are almost invariably better for having had that level of discussion. So I think that's, I definitely agree with your intent, and I think that would be our hope and aspiration. So we will bring the detail in. I think already we've heard conversations about the ways in which we can put supplementary information, which I think is a really helpful idea. And we will genuinely try and make this an inclusive process. But I wouldn't want you or indeed anybody else to think that the absence of those things at this stage is anything other than the fact we're talking to you very early on in the process, rather than we don't know the answer. You know, we're not at that place. The specifics around why certain numbers are the way they look, I think, is a really good point. Thank you. One of the problems, again, that the NHS has is that we work so often on normative numbers that we begin to just use them as shorthand without explaining why. So, you know, 10,000 this a year to be clinically viable, 500 births to be sustainable. There is a rationale which we'll share, and we absolutely need to be transparent about. But you're quite right, we do occasionally just assume that everybody else understands that number too. So I think we'll take that on board, and where we've put numbers or suggestions in, we'll be clear about that. And I think we've already had feedback about the way we articulate the issues around the standalone midwifery unit possibility, and I think we'll reflect on that and think about how we describe that. So I think we want to respond very positively to the things you've described in the way you've described it. And I think it's absolutely right that this committee should continue to talk to us through this process, and you should expect to see in the papers we're preparing and what happens next, us reflecting back to you the things we've heard and understood. So I would want that to be the case. But again, I think it's important that we do that together and iterate it, rather than seeing this as some sort of, here's our first attempt, not approved, here's our second attempt, not approved. This is a process we're working on together. So the consultation will run through. Eventually we will be talking to you about the proposals and formally consulting you on them, as opposed to talking to you about how. But I'm really happy throughout this process to keep talking to you about how we can demonstrate that we've incorporated your feedback into our thinking and the way that we're having our conversations. And that will be true right through the live process. You know, we'll have the opportunity, even when consultation is live, to understand whether or not there are further things that we should be doing there and then to try and broaden that consultation out. So I hope that offers some appropriate response. Thank you.
I appreciate that, and I appreciate the level of openness that you are presenting documents that aren't complete, and I wouldn't reject that at all. The reality is for page 47 onwards, how you intend to consult, pretty standard. I'm sure people have got innovative things where people can engage. They can chip those in, and there's a certain flexibility about that. So actually, the methodology of consulting is there. But I cannot help but feel that when you say, well, let's not try and confuse what we're consulting on with the consultation process, unfortunately, they're linked. Yeah. Actually, the content of what we're doing does, to a certain extent, steer the consultation. But I appreciate you accept the point. We've got a meeting on the 18th of March. I would definitely recommend that we see how it's changed. And so actually, as members of the committee, we get some reassurance that we're not just being patted on the head and sent away, but that actually the comments and the input is actually having a real impact on how you're handling this process.
Thank you for that. Maggie.
I think a lot of my points have already been taken up, but one thing I'd just like to reiterate about the supplementary, I think it's really important on the transport to have a transport impact assessment. We covered it earlier, and one of the councillors did, but coming to this council, we've seen Ashby, the problems we've had at Ashby, and that could have been addressed by a lot. We've got a lot of transport issues that were there. And I think reading the paper that 30% of patients will be affected, I think that percentage would be expanded because it's carers, it's visitors, it's everybody else. And I think transport is a major thing on this, and I think it would be important to put that into it. Talking about gaps that was picked up on as well, reading through it, I think I picked up on mental health. That to me was a gap, because if I was a patient, where do I fit into this? What's happening? Where are things going? It was just reading, so if you could just take those points on board, thank you.
Yes, thanks very much. Yes.
Thank you. So I'm hearing very clearly that you want to talk about how we consult. And it's very clear to me that you don't have to consult very far at all. In fact, beyond the papers for the meeting, to see how strongly people feel, I guess, that community and hospital services are not separate. And you keep mentioning how complex it all is, but it seems quite simple to me that you can't understand hospitals without understanding the services and the community stuff that happens around them. You talk about the kind of anxious, earlier you were mentioning feeling anxious and frustrated, and I know from people who've spoken to me that that's how we feel about, I guess, a seeming refusal to be able to see in its entirety how our NHS will be reconfigured as a whole.
So I take the point entirely. I think what I was trying to say was that we hear that and those conversations will be progressed. I think I find it difficult to address the issue directly, because the danger is that we end up with a complete master plan for the total configuration of the NHS, which, how many practices, how many beds, which I guess people would, in an ideal world, want to see. I think what we're trying to say is we're working on all of those things in real time. We're at a point where we believe that it is appropriate to consult formally, or will be in a couple of months' time, about the configuration of acute services. We recognise there's still an ongoing and live discussion about the detail of community services and primary care, and the point we've heard is that we need to be able to explain how those things relate to one another. What I don't think we will be able to do, or is to set out in the level of detail that we will that we're proposing to have for the configuration of acute services, the specific detail of how every other aspect of health and social care will work. There'll still be work ongoing about that. What we need to do, with your support, is demonstrate that we understand that those things iterate together, and so that we mustn't be in a place where what we're proposing to do with the acute services is so fundamentally out of step with what we're proposing to do for community hospital services or for primary care that the two things are incompatible. and we need to talk with you and the public generally about how we can be assured that is the case. I think we've heard that point, and we'll need to work with your help harder to explain how that is going to be addressed and how we can provide that level of assurance. Some of it will be process assurance, some of it will be actual facts and figures, but I hear the point entirely, and I think we take it on board. We will respond to try and provide that greater level of assurance.
If I might, Chair, just to add to that, I would totally endorse what Andy said there, because for the reasons I was talking about before, we ourselves need to be absolutely clear about that as well. It's not just a question of being able to justify what we're doing. We actually genuinely need to be sure about it, and actually being pushed on those kinds of issues is actually helpful. And I'm not being patronising there. It actually is, because it makes us sort of think, yeah, we need to be absolutely solid on this, because we actually do need to be absolutely solid on this, and not primarily for the purpose of satisfying the public, although that's very important. It's because we're responsible for the services. So we need to be totally right. But my point is, the two go completely hand in hand. They're compatible. So I think that's helpful. And we need to do exactly. I would endorse what Andy said about the approach there.
Mark, you wanted to say something?
If I may, please, Chair, and I get the point, but just thinking about it now, Andy said earlier on, we shouldn't let the fact that we can't do everything get in the way of doing something, which I think is important. And if you take that out of the context of the NHS, so some of the things that I worry about, particularly when I'm on call, are things like what's my availability of social care packages of care and social care placements. We could also be arguing that we need a kind of clearer line of sight into what's happening in social care in both city and counties before we do any of this. And it just kicks the can further and further down the road, not least because we still don't have any strong sense of whether it's a green or white paper, or when that's coming out, or when any of that's going to be enacted. So we absolutely get on a daily basis that all these things connect, and our job on behalf of you and others is to try and make sense of those connections. But the counsel of perfection that says actually you need a clear answer to social care, a clear answer to this, a clear answer to that before, as an example, you start putting bricks in the ground on a new children's hospital or doubling your ITU capacity, will essentially hamper your local NHS. And I just think there's a degree of reality around that. We don't deal in black and white. We live in the grey areas in health and social care and lots of other settings that you're familiar with.
Yeah.
I'll be brief. I guess I understand what you're all saying to me, that it's a movable feast. I guess the challenge is that the NHS has changed. We know it's changed, and part of that is a rise in demand, but also clearly part of that is the size of the cuts it's faced in the context of that rising demand, and that leads people to feel nervous about what next, and without being able to see it, some of it, however grey it might be, in its entirety, and the interplay between the community and the hospital services, that trust is not going to be rebuilt. Thank you.
Janet.
Thank you. I'd just like to pick up on a point that Gail has mentioned and really flag it for you when you're actually doing your consultation, is the issue of predetermination. It seems to me that in your document we are presented with a complete fait accompli that the two acute sites will be Leicester Royal Infirmary and Leicester Glenfield Hospital, with Leicester General being downgraded. Now, this has caused a lot of unrest in the local population, and I think it's something that probably you need to explain how you arrived at that decision to downgrade the General and focus on the Royal and Glenfield, and cover your own backs really against if you can, against accusations that you've made this decision without consulting the public, because effectively that's what the document says. So it's just a point.
Thank you. So in terms of consultation over many years, Wherever possible, I think we try to consult people on specific proposals because that enables them to give a specific response. There are some times when there is genuinely no correct answer from a clinical perspective, and then you say, look, it could be this, it could be that, what do you think? I have worked with consultations like that where we said, look, you know, we need to call this for other reasons because clinically either's okay, but something needs to change. I think the point that I take out of that question is that we need to be transparent about why we've got this specific recommendation. It is underpinned with a very strong kind of clinical analysis and a rationale, and I think we're bringing it to we will eventually bring it to consultation with that understanding, so it's a specific proposal we want to consult upon. But I absolutely take the point that we have to explain why that specific proposal and not something else, or not, you know, or why it's not a more open-ended issue. Yeah.
I would just like to point out that particularly from the people to the east of the county and Rutland, that actually get into Leicester Royal Infirmary, where you're concentrating a lot of your services in the future, is extremely difficult and very costly. And I'm speaking from a personal point of view in that my husband has become a frequent flyer at Leicester Royal Infirmary. It involves a lengthy journey, a difficult journey. There's no we have no infrastructure to get us from our door to the Leicester Royal Infirmary door, and it's very expensive. So if I'm facing that, then a lot of other people are too. So
if I might just pick up that, we'd totally recognise the convenience of the General as a physical location for people in the east of our catchment area. Obviously, we'll rehearse now the reasons why, notwithstanding that, we need to concentrate our services, because obviously that's the part of the substantive consultation. And like Andy, I do take the point that where the consultation document might appear to start at a point partway through the journey at the moment, and we need to have a look at that. But clearly that was very much, those kinds of issues are very much what came out in our previous engagement work, as I referenced earlier on, and we will need to be as clear and as positive as we can be about what we're going to try and do to mitigate those issues. On which point, of course, working with local authority colleagues on the transport side of things is very important there, and we are having that dialogue at a very high level, by which I mean council leader, city mayor type of level. We've got that dialogue going, and we have committed at that kind of chief officer level or elected lead level to work very closely together to get as robust a transport infrastructure as we can to complement these proposals.
Oops. Councillor Bill.
As a visitor to this committee, it's very good to see some old friends around the table. Some of us have met for the first time on a public body, so this is very good. I think the exchange this morning has been very useful. I think colleagues have put forward some very, very valid points, and I get the impression that they are being listened to. I think this is so important. But just on a personal point of view, the fact that we are now getting 440 or 450 million pounds worth of investment in Leicester has to be welcomed by all of us. I mean, some of us have been crying out for this to happen across the whole of the NHS for years, and at last it looks as if it's now to happen, and I hope we don't lose sight of that. I suppose there's not many of us around this table who actually were here before the NHS. I think you might have been chairman. I think it might just be possibly you and I. But I think the older we get, the more we realise just how engaged we are with our National Health Service. It's something that some of us live with every day, and that's why it's so important for us to get it right. In a similar way to Rutland's issues, we have issues at Hinckley, of course, because we're part of the George Eliot hinterland, if you like, and so we sometimes come into Leicester Royal, sometimes we go to George Eliot, and one of the things that that brings in really is the ambulance service. So we're talking about here, we're talking about the acute hospitals, but many colleagues have mentioned the need to also ensure that everything else that's going on in the NHS is brought up to the same level. So we do really need to know whether the community hospital reconfigurations are really going ahead, because the delay in that process seems to go on for forever. So that's one point. We do need to try to assure ourselves that the ambulance services it really has been brought up fit to purpose to be able to service our requirements, whether we're being looked after in Leicester or whether we're being taken out of county. This is such a complex issue which is not something that we can afford to get wrong. I think we owe it to every single person in the city and county and Rutland to get it as near correct as we can. So this is an important process, and I've learnt a lot from what I've heard this morning, and I'm looking forward to being able to take these documents back to Hinckley, because, as I say, it affects every single one of us. Thank you, Chairman.
The point on EMS is well made, and of course they are a key part of this, and I will reflect on whether or not that's something perhaps we can draw out more strongly as well. But thank you, that's a really helpful point.
Yeah, thanks very much. I think it's you, yeah. I think no one else, yeah.
Thank you, Mr. Chairman. Just to reiterate what Janet and Gail has said, and the gentleman, Mr. Bill, there, about the ambulances. Rutland, we have villages east of the A1, and it's an 80-mile round trip to come to the hospitals in Leicester. So it is important that we consult with all the parishes and all the parish council, parish meetings. We have a parish forum in Oakham. I don't see the word parishes down on the consultation, but if we can notify all the parish councils, they have their fingers on the pulse, terminology, and they know who's in their villages and who needs help. And it is important if they get to know what is happening, it will be a big help. But those at the east of the A1 with the ambulance services and things like that, it's a long while to wait. So if you can take that into consideration, thank you.
Just to mention, Chair, one of our UHL non-executive directors, Andrew Johnson, is chair of parish council. I'm sure you know in Rutland, one of the parish councils. So I assure you, the voice of the parishes is heard loud and clear in Leicester.
No, thanks, John, for that. I mean, I'm also chair of a parish council, and I would be mortified if we weren't consulted. But of course, it also means that quite a number of areas in the county, and I don't know how the city works, is they're not parished. So we need to remember the fact as well. I mean, there are other mechanisms, but there are loads that we need to go through. Someone else? No. Yes, okay.
Thank you very much. My final comments on this is actually about how you reach out to people specifically, rather than the things you reach out about. And I'd like to support what Jeff says about using the parishes. I'm sure if you ask them very nicely, Rutland County Council will facilitate that for you, as we do have mechanisms being totally parished, whether as councils or parish meetings across the county, including our two towns. Can I also ask that when you come to Rutland, which I'm sure you will at some point in your, whether it's a deliberative or an outreach event, that you recognise that Rutland isn't Oakham. Oakham's important, but there's far more, and if you're the wrong side of Rutland Water, you never go to Oakham. So please bear that in mind. Also, I did actually mention to Mark before the meeting, can you think about your documentation, because Easy Read is great for people who need Easy Read, but it's not an executive summary, and it certainly is not great for somebody who has sight disabilities, when actually what you want is a black on white, sans serif 20-point Word document, basically. And if that's what you've got on your website, don't have it as a PDF, have it as a Word document that people can change the font to suit themselves and then print off. The government can do it for government consultations. I don't see why the NHS can't do that, and I think that's important. And I'm sure that all of us as councils, all three of us, have got some sort of access group to support people with disabilities, which should be one of your list of consultees. Thank you.
Okay, I'd like to summarise then. I think we've drawn our discussions to a close. Firstly, of course, as I said right at the start, we've had a petition in, and as far as my reading the petition and what they asked for, I think they've had an answer today. Will others agree with what I've just said? I mean, you've got it in front of you. I've got a few names on mine, but you've got. I mean, essentially, they're saying we call on this committee to ask for the document. This is the consultation document we put in the public domain. Well, you've now got the initial draft of it in the public domain, and we've already agreed with what you've been saying, Patrick, that the next document will be for another committee meeting, so it will all be in the public domain. So I see no reason at all why this particular request on the petition isn't already being met or is about to be met, put it that way. I mean, that's what it seems to me. But anyway.
Can I just ask from officers, we've got a meeting on the 18th of March, at what stage do you think the information that we're asking for will be at there? Forgiving the fact that NHC&I will have its own time scale. Sorry.
Very sorry. The honest answer is I don't know. I'd need to check and get back to you. There is a process we're working through. I'm very happy to come on the 18th of March. If it's available to put in the public domain, we'll do so. If it's not, I'll explain why and when it will be. But I've just got to be cautious because I haven't quite got the dates in my head about when the process gets.
As long as people who've come and the petitioners are aware of where that stands in the process.
Yes. I'm sorry I can't give you a straight answer. I will find the answer out and we'll get it to you well ahead of that time in terms of sequencing. But I don't want to say the wrong thing because I understand these are formal processes and it's important to be accurate.
No, that's good. So, but other than that, is agree what I've said? We've had the information today, and we will have more information, and that will all be in the public domain. We've obviously talked about this as being a pre-consultation stage and what we're hoping to do in the future. We've talked about the fact that the community services review is going to be done in parallel. But clearly, what we don't want to do is put them separately so that one holds up the other, but nevertheless they will be done. And we've also talked a lot about the fact that the communication and how it goes on. We've mentioned parish councils, we've mentioned a few other things. There's a whole range of things there, I think, that, and I know I've seen people typing away and writing things down. So, obviously we've also got our own minutes. So I hope we've thoroughly checked really through what you've provided. Thank you very much for that. And if that's what everyone's happy about, that we'll call this one a bit, and we'll go on to the next item. But thank you very much. So item 7 actually relates to a briefing paper that we received from the Leicester Mercury Patients Panel and Rutland Health and Social Care Policy Consortium, and it raised concerns about processes followed by the local NHS, particularly in relation to the NHS long-term plan, which we have later on in the agenda. But the briefing paper is, as you'll see in your pack, councillors, is at pages 19 to 25, and we've now had supplementary to that a response from the CCGs and the UHLs also been. You've had that separately. Now, John and Andy are going to stay for this, but I've also agreed that we'll have comments from Mrs. Jennifer Fenelon, from the chair, who is chair of Rutland Health and Social Care Policy Consortium, and Dr. Sally Rain, who is the chair of the Leicester Mercury Patients Panel. And we've allowed them a few minutes to present their paper, 5 minutes indeed. There's a. If you want to go to the end of the line. Oh. Thanks, Mark. There you go. Got a few more. You'll see there's a button on the thing in front of you, right at the bottom. But when you press that, a red light comes on.
Thank you, Chair, for accepting the briefing paper on today's agenda. My name is Sally Ruan, and Jennifer Funland is sitting next to me. The purpose of our briefing paper, and this follows on well from the last item, is to flag concerns about potential weaknesses in the NHS's position as it moves towards consultation. Our desire is to avoid a future possible challenge by identifying some problems now and making suggestions as to how investing time and close scrutiny in the coming months could reduce the future risk of extensive delay. We are fortunate after such a long wait to have the potential to invest heavily in our health service. And we recognise that this kind of investment comes around only once in a generation, and that the public are entitled to be assured that every pound is spent wisely, and that the needs of the people of Leicester, Leicestershire and Rutland can be met for the next 25 to 30 years. We think that the NHS could be vulnerable in a number of ways. I gather that the NHS have made a rebuttal of this or response to this. I'm not familiar with that, but I know that Jennifer is. But just first of all to say that we believe that there are some weaknesses in their engagement processes. We've heard a very strong defence of their engagement processes today, but I think there have been a number of comments around the table which reflect the fact that not all members of the public agree that engagement events have been as robust as the NHS likes to think that they have been. We're concerned about the fact that relevant information has been withheld from the public. So, for example, there isn't actually any reason in law why the pre-consultation business case couldn't already be in the public domain and updated as it needs to be. The papers for the system leadership team meetings have never been put into the public domain and so forth. So we have a concern that it's been difficult for the public to engage in a more informed way than might have been the case. We're aware that there was a meeting arranged by members of the public in Rutland in autumn of 2019, which the NHS refused to attend, despite the fact that that was precisely to discuss, how local health services would be changed. So I think there are different perceptions about how effective and robust public engagement has so far been. Second, we're aware that although, as Andy has said, the strategic intent is clearly articulated, actually the strategic plan has still never been seen. It's not been seen either in draft form or in finalised form. I gather it's with NHS England at the moment, but it's never actually been seen. And the draft was never offered to the public for the public to be able to make some comments and give feedback in it. So at the moment, from our point of view as the public, we don't have a strategic plan, or we haven't seen the strategic plan, but we assume that the strategic plan will contain details of the interrelated schemes and the mitigating provision, which will be needed in the community alongside acute provision. So we're concerned that there may be the danger that some of those early responses, particularly to the formal consultation, will not be sufficiently informed. So, and I think already has been raised here by a number of councillors and others, the concern that there is still no clarity regarding the future of community hospitals, and that the public, I think, can legitimately expect to know where they stand on community hospital provision when they're being asked to make an assessment of the acute reconfiguration plans. So what we're suggesting is that that we would like to see the local strategic plan, when it does finally become available to the public, and the details underpinning the hospital reorganisation to be subject to detailed scrutiny before the consultation process actually begins. And in particular, we think that it's really important that some of this complex information, for example, we've been told that the pre-consultation business case for the hospital is at least 1,200 pages long. One person said it was 1,800 pages long. We think these documents need to be in the public domain. We're suggesting at least 2 months before formal consultation begins, so that there is an opportunity to give a fair examination of those documents and to identify any issues that members of the public public may raise. We recognise that not everybody will want to look at that, but different groups in the public might want to look at different parts of those documents and may have useful feedback on those. So and again, we're concerned that early responses to the consultation process need to be adequately informed, or we may run the risk of failing the gunning principles. And finally, although we've taken advice from a fellow of the Consultation Institute, we are not legal experts. And what we're proposing is that the Joint Health Scrutiny Committee itself take independent advice from someone who does have a thorough understanding of how the law in this area is being interpreted by the courts, to make sure we don't run into problems down the line. We mention in our paper Mr. Nick Duffin, who is a fellow of the Consultation Institute, because he indicated that he would be willing to give an hour of free advice to the committee. So although we recognise that all of this might take some extra time in the coming weeks and months, we think it could head off much longer delays down the line in the event of a legal challenge. Thank you.
Thank you very much. Do either of you want to?
Thank you. Yeah. I guess there's two levels of response in my mind's eye, really. One is we've provided an account back to this committee, and I'm happy for that to be shared, on the specific proposals or challenges that have been put in, and I'm happy to kind of go through those. But I to be honest, I don't want that to kind of sound like a kind of jobs-worthy analysis of what specifically does the law require versus what doesn't it require, because I think, although we are clear about that and we have taken legal advice, and I think we do feel assured with our processes, in a sense that's not the point in my view. I think what I'm hearing and how we've reacted to this, I think, as a service and with senior colleagues, is to say we understand the misgivings that are being raised, and we want to talk practically to colleagues. I've already had a chance to meet with Jennifer in a group. I've yet to sit down with your group, but I hope I will shortly. We want to get the dialogue going, because the point of this is not, are we technically okay or not? The point of this is, have we got the hearts and minds of people on board? Are we proceeding in a way which feels safe? Do we feel this is going to really deliver? I think our view back to this committee is we can address the specifics, and we've put that there. I would really want to have an ongoing relationship to make this consultation as effective as we can. It is our view that we should proceed in the way that we've outlined, and I've already kind of addressed some of the sequencing issues in council questions, but that doesn't mean that I want to close the door on this conversation. I hear what you're saying, and I want us to have a discussion about how to make this process really robust. I would very much wish to continue in the kind of timetable and process I've described, but I would very much also wish to have a positive relationship to try and work through some of the concerns. And I think in particular, the concern that I understand, there are two elements to it. One is to be transparently clear about why certain things people expect to see in the public domain aren't, and there are reasons for that. And secondly, to be clear about how the wider story all tells together. I've heard that point very clearly today. So we need to be much better able, I think, to articulate how what we're planning to do in primary care, mental health and community services is aligned with the very specific proposals that we hope to be consulting on in the near future. And I would like, with this committee's support and colleagues' support, to continue to work on those things and try and address those concerns. So I prefer to answer in those terms, if you like, than to kind of get into a discussion about whether it's technically possible or not.
Yeah, thanks for that.
Could just expand on that slightly. In terms of the two specifics around, all of which came up in the previous discussions around the BCBC and the local response to the long-term plan, bearing in mind that the long-term plan nationally is already in the public domain and has been for some time. All that the local response will be how we implement that locally. Both of those will be in the public domain at the time of when the public consultation actually starts. So there isn't an issue. If I might, from the point of view of the person responsible for taking this project forward, I would. How can I put this? It would be very unfortunate to have to delay public consultation. To my mind, it's perfectly reasonable to publish the documents at the time the consultation starts. The consultation is 3 months long. There's plenty of time during the consultation to look at those detailed documents. It has been a shared frustration, which we've talked about in this committee before, that we haven't been able to put the PCBC as it then was in the public domain before. From a local point of view, we've never made any bones about the fact that we would have been happy to do that, but that's not the national rules. But it is absolutely the national rule that the PCBC is published prior to the start of consultation, and that relies on the start of consultation itself, relies on the approval of the PCBC nationally, as we talked about earlier on. So the two are in lockstep. There will be no start of consultation without a publication of the PCBC, and clearly any delay after all this waiting is not really where we want to go from a project management point of view.
You had some comment.
Mr. Chairman, can I just make a point from Rutland, which sits with your 2016 plan still on the website, which says we will lose our DGH and our local community facilities. That has never been updated, so that is extant at the moment. Can I remind Mr. Williams that the Lansley tests for reconfiguration, especially Test 5, requires that if there's going to be a shift from acute to community, then those services should be either spelt out in detail or preferably in place before that shift takes place. We can't do one and not without the other when it comes to the flip side of the same question. And we would ask that the community a plan, in particular the reconfiguration of community hospitals, is speeded up very fast so that the two can be put together and meet the requirements that could lead to a legal delay if they're otherwise not met.
So just
we've
on
already
that
obviously discussed that
point, I had the chance to meet with Jennifer and colleagues and made that point very clearly. I think we met within a couple of weeks of me starting, and we're due to meet shortly again. I think there is an event that I've been working with colleagues in Rutland trying to come together, and I hear the point about needing to get these things sorted out differently, so I will follow that up with you and we'll try and get that addressed. So I absolutely understand that we need to update and clarify those issues going forward, and I'm really happy to commit that we will do that. What I don't believe is that those things are reasons to delay this really important process. I think they're exceptionally important things to do as well, and it's in that context that I'm really committed to going forward.
Yeah, do you want to make a comment? I mean, we're needing to move on because obviously we've got 1,000 things to do yet, but by all means.
Thank you. It really concerns me to sit here and hear the Chief Executive again say that the pre-consultation business case will be in the public domain at the start of consultation. It's a very long and complex document. I think if people, and it will contain financial information that it's reasonable that some people will want to have a look at. It will contain a lot of information about the assumptions upon which the proposals are based. And yet what we're saying is, well, sorry, members of the public, you're not going to get that until we're actually at or almost at the consultation, and you will just have to digest that as quickly as you can. I mean, my understanding of consultation processes is that you tend to get a spike of responses very early on in the process, at the beginning of the consultation process, and then you get another spike of responses towards the end of the consultation process. Now, it's very difficult to see if the PCBC has been released, for example, only a fortnight before consultation, how there can possibly have been any kind of public discussion and public debate and consideration of some of those details which some members of the public will want to engage with. So, and again, it worries me because I'm sort of now hearing sort of different points of view, different legal positions coming up, that we're in here something which is quite a contested area within the law. And again, I would an hour of free advice is being offered by the Fellow of the Consultation Institute, and I think I could see little that might be lost by taking up that possibility. Thank you.
Well, you've heard the response clearly. I mean, anything else you need to add to that? I think at this stage, we've obviously discussed for now nearly an hour and a half the detail of how the pre-consultation, the fact that Councillor Kittrick here has got assurances that we'll have the consultation paper before our next meeting, which means it'll be in the public domain at least a week before that, and that still won't be finally released. There's a whole load of those. We've already heard, as part of the agreements, is that the CCGs will be, as normal, do speak to the Consultation Institute. So it isn't anything that extra we have to have. I think we've heard enough today to convince me, anyway, that the CCGs and the UHL are aware of the issues. We've had a lot of discussion about it today. You've duplicated quite a lot of what Council has already raised. But thank you for that indeed. And I think, therefore, at this point, but yeah, Patrick.
Sure. I think there is a middle way through here, and we didn't really focus on it, is I think the demand to say, well, the consultation must be delayed until the PCBC's been in the public domain for 2 months. Well, the word I hear is delay. Actually, is there a middle way about this, which is not necessarily to delay the public consultation, but to extend it beyond the 12 weeks? Because the reality is this is not a document that people will probably, the pre-consultation business case is not a document people will be able to conceive of large parts of it without interpretation. And it's not necessarily that I'll read it and then I'll know. I'll read it and I'll have to seek guidance from people. Or I might wish to draw other evidence. So therefore, I don't wish to see any delay to the start of consultation. But given that in your draft document, you haven't actually said what the dates of the consultation are yet, that actually there is a discussion about how long and how appropriate that consultation is. Because clearly, it could be the case that if we wait from Whitehall for NHS E&I, we might actually find that a lot of our consultation then tips over into summer. That is a possibility. And therefore, I've got on the two matters at hand. One, I would urge, not particularly that there is an absolute delay that we outline, that the PCB arrives and then there's 2 months delay before we can start the consultation, but that actually we have a discussion when the PCBC does arrive, how long the consultation is. So we give that window to take in the complex stuff, but we also give an opportunity to get round all the parish councils and all the various people. In terms of who we invite, I'm quite happy to have a discussion with the chair outside of the meeting about how this follow-up that we're going to have on the 18th of March is constructed, and how best scrutiny committees take evidence. Taking evidence from third-party sources of expertise is quite good practice. I wouldn't say the end of the world. I think we'd probably be a little bit stretched if we listened to the guy for an hour. But if he'll come along and put in relevant points from a third-party point of view, I think it certainly does demonstrate that we've disposed of our duties of scrutiny quite well. But we can have a discussion about the practicalities of that outside of this meeting. So I just want to put that on the table and maybe get a quick response in terms of the expansion of the timetable rather than a delay and then a commencement of the time.
Okay, thank you. And thank you for the kind of thinking constructively, and we'll reflect on that, I think. A couple of things that I think it's really important to say. First of all, I think this committee has an absolute right to expect that we do our job properly, and I think we've provided, and I've tried to be, I've tried not to be too officious, but I'm very clear that I think we have, and I think we've provided the evidence for that. We have taken advice, and you would expect us to, including from the Consultation Institute. The issue about the consultation business case, to be absolutely clear, until it's signed off, it doesn't exist. What we have is a proposal, and we haven't got one agreed, so there's nothing to publish. That only exists at the point when the centre say, yes, this is now signed off. Then there is a document. At that point, or as immediately after that point as we can, it'll be in the public domain. and it absolutely will be in the public domain because we can't consult upon a proposal until that document's signed off. The consultation is 3 months because it is a complex matter. Extending it, and there are occasions when I've been involved in consultations where we have extended, and that can be helpful, but we've got to be careful here that we don't also then create delay in the overall programme. And one of the things we would need to give evidence to and think very carefully about is it possible to do those things without slowing down the overall programme. There is, and I don't want to overemphasise this, but we mustn't be blind to it. There is a massive opportunity cost in delay. We're not proposing to invest £450 million in reconfiguring acute maternity services because everything's absolutely fine now. We're doing it because there are real challenges that we want to address. Any delay, even a relatively brief one of some months, has two impacts. One, it creates a perpetuation of some of the problems that we're actually trying to fix through this development, which is really undesirable. And the second thing it creates, which is a relevant thing in the public domain actually, is it creates cost escalation in the scheme. Capital schemes move in their value a lot, and 4-5 months delay, 2 months delay, even a couple of months delays cause pressures operationally. Now, I'm not suggesting please don't misconstrue this as me saying we need to crack on because money's an issue. The point that I'm making is that we've got to weigh collectively, all of us, the opportunities and the benefits that come from having, for example, an extra some extra weeks to scrutinise a document versus the service, practical and financial consequences of doing that. And if there are other ways to address these issues in parallel as well as through a formal consultation, then I'm really happy to do that. I'm very happy to share with you our advice. I mean, you may have had different advice. Lawyers sometimes do give different opinions, but we'll very happily share with you our advice. If there is another way or we're missing a trick, I'm absolutely open to that too. So we're not in any way trying to conceal anything. We are simply doing the job as best we can as we understand it, and I'm really happy to kind of share with you, indeed anybody else, the advice and process we've been through to get to that place.
Oh, thanks for that, because I think open dialogue sounds like a very useful part.
I really must just say very quickly, we're not talking 6 months. We are sometimes talking about a matter expanding it for 4 weeks, which in the life scale of this project is not long. And I would particularly highlight, if you go down to Liverpool and you see a building site, which is where the Liverpool Hospital was, because people didn't look at the numbers closely enough, that mess has cost that project a hell of a lot more than 4 weeks.
Michael, we don't want to go on about this, but yeah, please.
Thank you, Chair. Just a couple of things, really. The first thing, when kind of looking at the petition, it makes reference to other trusts that have released information before, I would imagine, it was signed off. So there's a question about, did that happen? If they did, how did they do that? But just as a kind of, that then leads on to the question about I get the point around the pre-consultation business case, but there is a heck of a lot of information that has been released over the years whilst this conversation has been going on. So could there not be almost like a briefing document that could point to people to what's already out there, that can kind of give them the chance to maybe kind of go through and review the details that have been released and are not likely to be changing at all? So you're almost kind of saying to people, this is already here. Take that, try and use that to kind of build some context, and then when the pre-business consultation case is out, then that fine nuanced detail might make a little bit more sense.
Yeah, that sounds, I think, looks like you're getting some nods from the... that sounds like a good one. So I think we are where we are. I mean, I had thought about perhaps having a recommendation at this point, but I think the recommendation, it seems to be clear that we encourage some dialogue between the CCGs and clearly the panel and the Rutland group, and that also the point I think Patrick made about whether there's any way in which the period of the consultation area might be bit more flexible than it currently appears to be. I appreciate there are certain regulations on, but sometimes in a process like this, where it is an extremely complicated process, not just the 450 million, but clearly the community services side, that we do need to be sure that we are doing. And I take the point about Liverpool quite. That was going through my head as well, exactly the same. So I think if people are happy with that, then I think I'd like to move on. But thank you very much for attending today. Thank you for the members of the public that are still here, and thank you very much to you, John. Right, we'll reconvene. And at this stage, I think we might be finished by about 1, if we're all, quite. Well, I thought it was important that we got, the discussion that we did have. Right, Andy, I think this is your bit, isn't it?
So you'll be relieved to know I've been joined by another colleague, Sarah. So for the sheer sake of variety, Chair, we'll hear another voice. I'm sure everyone will be glad about that. I'd also like to suggest, Chair, with your agreement, that rather than...
Excuse me, just can we have the meeting outside this meeting, or your meeting, please?
I think you've got the slide deck in front of you, and I think rather than talk to a screen, we're just going to talk you through the slides in front of you, if that's okay, because I think it can be a bit distracting if we're talking in the back of our heads to you. So what we've tried to do in this presentation is just to remind ourselves what the long-term plan for the NHS is, and of course the long-term plan for LLR is the same as the national plan. That's the whole point. But there are some specific things that we're doing to implement it, and some specific things that, of course, are particularly relevant to our area. So what Sarah is going to do is to talk us all through that. We've also concluded at the end with just some thoughts, actually, about where there's some great opportunities for collaborative working, and I'm particularly keen to continue the positive dialogue that's just started that I've been having with the mayor and with the council leader and with Rutland Council. So just some thoughts about the future, and then of course between ourselves, Sarah and myself and Mark, will happily answer any questions that we can. So having heard enough from me, I'm delighted to hand over to
Hello everybody. So as Andy said, we just wanted to take you through what the NHS long-term plan says. And as we said earlier, our response to that is effectively how we're going to implement that locally. So there are 4 main things in the long-term plan, which was published in actually this time last year in January 2019. It set out a new model of care for the 21st century, and I'll talk a little bit more about that in a moment. It asked us to very much focus on prevention and health inequalities, and particularly some of that discussion we had earlier around how do we invest more money in community prevention and general practice and less in the acute sector. Further opportunities on outcomes, particularly around specific clinical services such as long-term conditions, maternity and neonates, etc. How do we make a real difference in our NHS workforce? It's one of the biggest issues in the NHS, as most of us know around this table, is workforce. And then how do we use digital into the future to really enable an NHS of the future? So in terms of how we have taken that and how we're responding to it locally, I think one of the things I need to say is a lot of the stuff that's in the NHS plan is stuff that we were doing prior to the publication of the NHS plan. I think it's really important to set that out. We have had a long-term vision since our Better Care Together programme in 2014 commenced around this shift of a much greater emphasis on primary community and prevention services. So we were not starting from a low base. We are starting from our plans that were set out in 2016, and actually everything that we've done since then as a system, as an NHS, and with our partners, particularly local authorities and social care and public health services. So in terms of how we are developing integrated care locally, so we have got a focus on how commissioners are working together across LLR. One of the things that the NHS plan asks us to do is to consider our form of CCGs. As you know, we've got 3 across the patch at the moment. There was a decision made back in, I think it was 2018 now, at the back end of 2018, that we would have a single management team across those 3 CCGs, and obviously Andy was the first appointment to that process, and he's now appointing his single management team, and we're in the process of doing that and adapting our governance arrangements to manage 3 organisations through a single management team. We're also at the very early stages of engagement with our stakeholders on the future form of CCG. So do we stay with 3 CCGs? May we go to 2? May we go to 1? And that will be an ongoing process that we go through over the next few months through engagement into consultation and then into a final decision about what we do about that. We've then looking at how we work collaboratively together. And we are bringing our NHS partners together and having a different dialogue with local authorities, and Andy might want to say something about that a bit later on in the presentation. One of the other big things about the NHS plan was the development of primary care networks. For those of you who are not familiar with what they are groups of GP practices working together to deliver services on a bit more of a larger scale than you can do at an individual practice level. And we were asked to set those up by July of last year, and we've got 25 of those across LRR. And we are continuing to develop our wider partnership working. In terms of our service model, it is very much the model that was described earlier, that model around much more in prevention, primary care, community, and less so in acute. And alongside that, we were asked in the long-term plan to really push an approach to population health management for our populations, which is about looking at the whole population, what their needs are, and how you can deliver different services to different cohorts of people. And we are really developing that across LR at the moment. And we're working with our public health colleagues on our prevention agenda, and we've got a real drive on reducing health inequalities. And actually, I think that's one of the things that we really want to work collaboratively with local authorities on, because obviously, as we know, most of the things that affect health are not actually health service related. They are very much the things that local authorities are accountable for. The plan also asks us to set out our plans around personalisation and how people can get much greater control over their health. Improving primary care is a key responsibility for us and a key area of focus, and I'll give you a little bit more detail about that in a moment. We've talked a lot about the redesign of community services, so I won't go into a lot of detail about that today. Pressure on emergency services, still the big focus on improving our emergency services through ED and our out-of-hospital emergency services as well. And a real requirement in the long-term plan to transform our elective care, and I'll give you a bit more information about how we do that. And then in terms of improving care and quality, there are some real specific clinical standards that we're being asked to deliver, particularly around children's and maternity, mental health, cancer, long-term conditions and those sorts of things. And they were all part of our plan before and continue to be going forward. So I've just wanted to pick out a few things I think that would be which demonstrate the progress that we've made and some of the things that we want to focus on in each of these areas over the next few months. So in terms of primary care, I think we've had a lot of conversations in the different councils about primary care, its resilience and its sustainability. I think most of you will be very familiar with some of the issues that we face and some of the challenges that we've got around primary care. But over the last few years, there has been a number of initiatives that help us do some things in primary care. So we've had some money to help us support primary care resilience, help practices to recruit new members of staff, improve their processes internally to allow them to become more resilient, to change their skill mix, that sort of thing. And also to focus on the care of really complex patients. We've also had funding available that's enabled us to put over 100,000 more appointments in over the last few years. That's been done slightly differently in different patches. So, for example, in the city, we've developed hubs. In the county, it's been very much more based on putting those additional appointments into practices. We have been very successful actually in recruiting international GPs. So there's a national programme around recruitment of international GPs, and we were in a cohort that recruited sort of at the end of last year and this year. We've got 14 international GPs now working in the patch, and we are in the middle, I think, of doing the interviews for the next cohort of those. And they've been working for about 2 or 3 months, I think, in practice, and the feedback to date has been very positive, actually. As I talked to you earlier, we've had 25 primary care networks established. They are in the process of recruiting to clinical pharmacists to support their pharmacy, to support their wider teams in things like medicines reviews, supporting patients with medicines, and supporting doctors with minor ailments and those sorts of things. And they're also in the process of employing social prescribing link workers to support patients with those non-medical issues that they quite often come to their GP about. So how do they get into befriending services? How do they get support with debt and those sorts of things? And our big focus for this year is going to be how can we concentrate on improving access to primary care, and particularly how can we use digital, different skill mixes, all of those sorts of things to really improve our primary care access, because we know that that's the biggest issue for patients that we've got across LLR. So that just give you a bit of the flavour of some of the things we're doing around primary care. In terms of community services, so we've had phase 1 of the community services review was touched on earlier. So that was about how do we redesign our services to provide a home first option. so that more people can remain at home rather than go into hospital, or when they come out of hospital they can go home straight away instead of into an intermediary phase. And that went live just before Christmas and is continuing to implement that model. That's included having a 2-hour response to crisis, and it was announced yesterday that LLR is one of the Ageing Well pilots, and that will continue to support this work and ensure it gets accelerated further. So that's really good news for us in LLR. We're only one of 7 pilots across the country. As part of that redesigned services, we're looking at bringing in 7-day therapy services into the community. Again, that will support patients, particularly when they're coming out of hospital at the weekend, which hasn't been available in the past, and that's due to start this year. We have got more therapists working to reduce the waiting lists, and the further investment is the Ageing Well that I have just described. So there's some of the things we're doing in community services. I'm not going to dwell on mental health if you don't mind, because you've got a presentation later about the things that we're doing around mental health, and that's very much a collaborative approach to mental health, but much more around improving access, getting earlier intervention and those sorts of things. We've talked about the acute hospital redesign stuff this morning, but I'm just going to talk to you a little bit around what we've been doing around elective care, and actually our elective care lead is in the room to talk to you about the next item. So we've done a lot of things in elective care, or planned care as some people call it, to try and improve processes and get people to the right place at the right time with the right specialist. So that's what our referral support service does. And that's made sure that in the last year to 18 months, 24,000 people have actually got the right care in the right place, rather than going to a different place and then being referred back. And that's meant that more people have been treated in primary and community care settings. So part of that last shift I talked about earlier. We've worked very closely with GPs to support and educate them on how to improve their pathology testings, and that has actually resulted in 12,000 fewer pathology tests or duplicate tests being made, which is both great for the patients, for the workload at the hospital, but also on cost as well. We have done a lot of work on our procedures of limited value, and I think all scrutiny committees have seen that in the past, so you will have been familiar with that. And we're doing a lot of work, of which the hip and knee example in here is a great example of how can we redesign our follow-up services after an operation for them to be much more efficient and effective. And again, that's one of the things that we want to focus more on in the following year, particularly how do we use digital and other means to change the way we do outpatients appointments. And there is a specific requirement in the NHS long-term plan to reduce your follow-up outpatients by 30%. So every system across the country will have to do that over the next few years, and that's part of our focus going forward. So I think in terms of the key opportunities that the NHS plan brings to us, there's a few things I just want to say, I think, in summary, and then I'm just going to ask Andy to talk about the developing relationships, if that's all right. A real move from reactive medicine into proactive medicine around, how do you increase your prevention services, how do you get more how do you get people having more control over their own conditions and those sorts of things. Bigger investment in primary mental health and community services. There's a requirement in the NHS long-term plan to do that, so it's not
I think your red light.
Sorry, is that better? Reconfiguring our estates is the thing we talked about earlier, and really key, I think, for us in LLR. We have got a real job to do on our workforce plan collectively, in terms of how do we adapt our new workforce and how do we grow our new workforce to the changing environment that we have in in the NHS going forward. We have got a quite well-established workforce group that's doing that, and since Andy's came, he's now taken over the lead for that role. And a real focus for us about how do we use technology and how do we really grab hold of that new opportunity that is in technology to support care. So that, do you want to just pick up the bit about?
So just to conclude, I think the final area, coming into this area, I had the opportunity to meet at a fairly early stage, I think within the first week or two, with the mayor in the city. I've met just recently this week actually with the council leader and members of the cabinet. I've talked to Councillor Walters in Rutland from a perspective of Health and Wellbeing Board, listened very carefully to the feedback I've had from senior officers, John Sinnott particularly in the context of the County Council. And there was a very strong theme that basically that I heard and that other colleagues were aware of, that said the engagement between the NHS and local government is not working anything like as well as it should. We don't feel like you're having a direct relationship with us as an executive, as the actual elected leaders of the councils, the people with the executive authority, and the processes you're asking us to join in with, whether they're ICS or STP, they don't work for us, they cut across our governance, they don't fit with the way we do business, and it's not effective. And so I've tried very hard with support of colleagues to reset all of those relationships, and I think there's some early indications that that is starting to work, and it's particularly important that we do so because I think there's a really very clear agenda that we need to be working on and could usefully work on together that's much bigger than just the way health care is organised and delivered. And we've put some things on this slide, but I know, for example, this council in particular, the County Council, has taken very seriously issues around climate crisis, and I know that the Mayor's very concerned about air quality in the city. The reasons we're trying to change some of these things on outpatients, for example, is not really about money. Actually, it's much more about convenience to patients, where we don't want people to have to make quite difficult journeys often for relatively short contact time with clinicians when there's another way of doing that. And equally and ironically, the way we configure services is a real problem. So just a very simple example, the footfall in LRI as it currently stands means that hospital is at the centre of one of the poorest air quality areas in the whole patch, and it's because, in part, and quite a large part actually, because of the transport infrastructure and changes around it. Now, the proposals that we talked about earlier will alter that dramatically actually, because they reduce dramatically the footprint of the footfall in LRI and move it into other areas. And that, apart from all of the reasons we've talked about why that's a good thing from the delivery of healthcare, it has a massive secondary benefit in terms of things like air quality, carbon neutrality, sustainability in a kind of an environmental sense, never mind an NHS sense. So there's quite a lot of excitement actually, I think, about how we can kind of work together. But the key thing, I think, is to kind of reinforce that I think we have listened and heard very clearly from council colleagues that we need to do things very differently. We're just about starting the process of doing that, and I hope that gives us a really positive way of working together going forward. So I hope that's helpful. Obviously happy to pick up any kind of questions or issues with Mark and Sarah.
Thank you very much. That's useful too, as you say, new broom and all the rest of it. But nevertheless, it's good news. Michael.
Thank you, Chair. There are a couple of points. I mean, I think as far as primary care is concerned, it's massively reassuring to kind of see the investment that's kind of going into there. It certainly is, year on year, the most common issue that patients are raising, and I think there's an issue around the inconsistency of patient experience across GP practices, and about there seems to be very little done to those GP practices that aren't offering what I think most of us would consider to be a good service, and how that's kind of managed. I think I'm not going to kind of go into too much detail about primary care networks, but I think that's something that we certainly need to kind of keep our eyes on and see how that manifests within things going forward. I I did want to just kind of quickly touch on, you mentioned about the hip and knee, what's happening around that and the reduction on outpatients. And I personally would just like to say that it's really refreshing to kind of see how the move to try and create efficiency is actually by empowering the patients to make self-determined choice around their outpatient care, which is a great thing to see, and something that if more of that could happen, I think that's certainly something that people would really respond to, because you're putting the choice back to them, because you're trusting them to be able to make the choice of what they need, and it's about that patient choice, and it's great to see. And just kind of finally, as far as the, well, actually, there's a couple of things. With the community services redesign, you mentioned about workforce, and what's been emerging, certainly around Leicestershire Partnership Trust, is they've underestimated the amount of anxiety and uncertainty it's created within the workforce. So within the kind of the larger scheme, just to kind of try to kind of make sure that that's really taken into account, because it is unsettling. And, you know, this lives and dies on the workforce, to be fair. And the final thing, just with regards to the digital offer, it's about the inconsistency about how that's rolled out. Certainly within kind of primary care, that you've got some practices that are really offering that alternative options about booking appointments online. They've got much greater functionality and control, but that's not something that's replicated across the patch.
I mean, just to acknowledge those things, I think, Chairman, and say that the point on consistency is particularly important. So one of the interesting conversations, just very quickly to share, with Vi Dempster in the city, and yesterday with, or in the last couple of days with the council leader here, is a desire really to try and have a much more explicit agreement with the public at large about what good primary care is, because part of the problem, I think, is that we've got differing views in primary care, we've got differing views in policy, we've got different expectations from different parts of the community depending on their age and gender, and as a consequence, even when we've made demonstrable changes that should in theory improve access, and we can show physically those things are there, often people's lived experience is it hasn't made any difference at all, or in some cases it made even worse. So we've got to have a much more candid and direct conversation with people about what it is we're actually trying to do here, because I think this mismatch in expectation is at least partly is partly responsible for the fact that there is a growing kind of unhappiness with the responsiveness in primary care, and actually GPs feel that too. They're frustrated and challenged by the fact that they feel like they're trying to do more and more and it's not working. So I think it's a great opportunity to work together to kind of have a look at that. It's something we've talked about in Healthwatch, and I'm really keen to kind of do that in a participative way.
I absolutely would applaud that kind of focus around what is the expectation of a service, and the discussions that we've had, and trying to kind of give not only the kind of the members of the public using a service, but also the clinicians delivering a service, a much kind of clearer, okay, this is what to expect and this is what we will promise. And as I say, I think kind of setting that kind of realistic expectation, I think will eliminate a lot of misunderstandings and frustrations that come from assumptions that people make.
David.
Just briefly, Chairman, I think yes, we mentioned air quality in this report in relationship to the city. Air quality affects us all across the county and Rutland to a greater or less extent. We are poisoned every time we enter the motorway, and it's getting worse, I think. And so, I mean, I'm not sure what we can do about it immediately, but it's not just a city problem. It's across the whole. It's across the whole piece, and the levels of particulates and all the rest of it has to be reduced because there's so many people who are suffering from respiratory complaints, as we all know. This exchange about primary care, I'm always reluctant to be critical because so I'm not saying this applies to me. But there are reports, of course, that people have difficulties in getting appointments. All this business about you have to ring before 8 o'clock, and you have to stay on the phone to get an appointment. And of course, the receptionists are the guardians of us all, which is another matter. And the fact that you can only complain about one problem at a time in certain practices. There's a whole range of issues here which is so important to all of us that I'd like to see a further report on. I'd like to see a further report on air quality from the NHS point of view, and from the need to standardise practice across the GP surgeries as well, if that's possible, Chairman.
Well, I'm glad you raised about the air quality, because I would have done it anyway.
Both of those are really important issues, and absolutely air quality is an issue right across the whole of LLR. There are rural dimensions to it, linked with agriculture and then the industry infrastructure that exists in the rural areas. Just to illustrate the point, I commissioned in my previous role an economic impact assessment of health in this respect, and something like 11 to 15% of all daytime traffic is associated with healthcare, either people driving to people's homes to deliver services, or patients coming in, or staff going to work, so it's a massive driver. The way we source materials, the way we use renewables, but more fundamentally, the way we organise our services. There are hundreds of thousands of outpatient appointments that take place on a face-to-face basis. Significant numbers of those could be done in a different way. And that would give tremendous convenience to people and reduce demand. So air quality, carbon neutrality, these are really, really important issues that I think the NHS has been really slow to wake up to, but I'm really keen to try and get on the agenda. The primary care access thing, absolutely get it, and it's a perfect example. The reasons why, just to because I think it illustrates the point beautifully, a lot of practices restrict access to appointments because their learnt behaviour is that appointments booked too far in advance tend to get very high levels of DNA. The reason they do that, of course, is because patients can't get an appointment, and therefore they book them just in case. And so what we're ending up is people game the system, so people try and control it, people try and work out how to get round it, and instead of actually fixing the problem, you end up with these kinds of measures in place, and it makes people really cross. It makes the staff in the surgeries feel like they're under siege. It makes the patients absolutely seethe, and it's all done from a point of view of trying to get to trying to fix a problem. But it's why we need to stop it, take a step back, and say, actually, there's a better way. And I think we just need that kind of direct honesty at a much more collective scale with people. People will use services responsibly. I trust people to. We do it all the time. But the moment you start putting artificial restrictions, things, people game it. It's like putting a clocking in point in a factory. People work out how to lie about when they start. If you just treat people to turn up, they turn up. So we've got to reset that. Both sides of it, actually. We've got to trust our doctors. Got to trust our. And I think it's but it's amazingly difficult to do. So we've got to pick up our courage here and start a new type of conversation with people about what actually good primary care access looks like, because it isn't having another 20,000 appointments on a Saturday afternoon. That's not going to fix the problem.
Yeah, just while you were speaking, I had a quick check on my NHS app, of course, to see when I could possibly get a new appointment at, I don't want one, but at my doctor's surgery. And with all the various buttons I've had to press, the next available appointment is Thursday, the 20th of February. Tells it all, doesn't it? Amanda.
Okay, I just wanted to to sort of follow up on points already made in terms of consistency, and you forgive me to localise in terms of my particular practice in my patch. We've had ongoing issues for 5 years. It is constantly all I deal with, and it goes in and out in phases. For me, as a local representative, particularly looking at primary care, is consistency. But can we speed it up a bit? I get a report, we just can't get GP appointments, there's no access here, there's no access there. We then go back to the practice, and 3 months later they then respond to us, and then we go, oh right, that's the issue. It takes too long. And all the while, the service that's offered to patients gets disjointed and it breaks down a little bit. So consistency really important, but those practices that aren't working, can we get on top of it really just much more quickly? It takes too long. And hopefully, I mean, the primary care networks enables you to reset some of that, and it'll be, you know, people have heard me talk about this before. I'm really worried about capacity and availability of colleagues. We're short. We're recruiting international GPs because we're short of GPs. It's not going to be long until we're short on all the other medical areas as well in terms of colleague. And how are we going to manage that? How are we going to deal with that? Because if 25 areas are recruiting at the same time for the same people, it'll be, you know, there'll be all kinds of different decisions that are made. It's going to be a lot of organisation and management is how we're going to manage that.
We've got to change from the NHS's response to this at the moment has been, how do we get more people like the ones we've got so we can get them to do more stuff like the way we do it. I mean, that's understandable in one sense, isn't it? But it only gets you so far, and it won't fundamentally change these things. The conversation I had with Vi Dempster, and I will personally, I know she's a city councillor, she kind of expressed to me almost exactly that kind of sentiment, and I sat down with all the GPs in, you know, the GP leaders in the city with her and said, we need to hear this. You need to hear her tell you what it feels like to represent people who are fed up they can't get to see you. And they heard and listened to that and responded. She also needed to hear them say to her how soul destroying it is at the moment to try and deliver really great clinical care in primary care when you're awash with a demand that never seems to go away, you haven't got the resources you need and all the rest of it. So we've really got a problem. You know, it's a time for a step change, and we certainly we will continue to try and recruit and have a great workforce plan and a training plan, but we need to do things very differently. And I think in primary care we've got to be much more honest with the public about actually primary care is not just about GPs, and actually a lot of what people expect primary care to do isn't appropriate. So it's no good having antibiotics for colds. It's no good presenting with conditions repeatedly to different parts of the same system. It won't help you. Equally, it's no good us telling you your first available appointment is in February, because that's useless, isn't it? You know, so there's got to be a complete reset of that relationship fundamentally. And I think what we're now saying to our colleagues and trying to work with them, and I literally just this week had this conversation with the leaders of the council here, is it's time now to kind of have a really active conversation, place by place, district by district, patch by patch, or with the whole county or city or with Rutland, to say, let's reset this button. Let's kind of work out together what we think good looks like. What's the role of the pharmacist? How do we respond to you in a timely way? And it can be done. I know it can, because I've done it where I've just come from. We made a promise to people in Sandwell and West Birmingham that if you were in a certain groups of people for certain things, the answer is we'll see you today. So parents of children who are under 5 years of age, if you rang before lunchtime, you saw your doctor that day, not 2 months from now, that day. But the quid pro quo was, if there are a bunch of other things, we might come back to you by phone, or we might ask you to try a pharmacist first, or we might say to you, actually, look, we don't do this, to be honest. You've got to think about a different solution. But we were really clear, and it worked up to a point. So I want to build on that learning. I want to bring that approach here and say the right time for some people to see primary care is now. The right time for other people is next week. And the right time for some other people is not at all, but here's an alternative. Here's something actually better that we could commend that you go and do instead. And I just think we need to have that conversation. I want to do it, the GPs want to do it, the public want to do it. Your role as leaders of the public, if you like, and advocates for them is really important. So I'm excited about how we might do that together, actually.
Janice.
Thank you, Chairman. In the briefing paper, I'm pleased to see that there's going to be many more appointments available through the year to see GPs early mornings, evenings or at weekends, because I do think that will relieve some of the pressures, and especially for people that goes to work, then they can get in the morning before they go, or at evenings, or even weekends. To see your surgeries closed on a Saturday, I think is not acceptable. And my own surgery, where I live, minor operations are now performed, which is good because it saves you from having to travel into cities or whatever. I had to visit Leicester Royal Infirmary, and the queue was so far away. My husband had to drop me off, park up the town, and then I had to go in and walk up to the town. So the air quality, obviously, is, like you've touched on, is dreadful. I mean, they've built a new car park, so, you know, obviously it's not adequate. So what are your thoughts on the parking facilities in that particular hospital? Thank you.
Thank you for your heroism, Andy. It wouldn't be scrutiny without a question on car parking, would it? But we shouldn't be glib about it. So yes, we built a new multi-storey. In fact, John, my gaffer, that was almost his first thing he did when he arrived at UHL 6 years ago. One of the things we know about car parks are a little bit like extra lanes on the M25, is you know that if you build them, then people ultimately think, actually, yes, this is getting better. More of us will drive into the Royal, which is what's happening at the moment. There's also a bit of local difficulty at the moment that the barriers aren't working quite as effectively as they ought to be, which is causing an even further tailback, which is affecting some of your residents, Patrick, in Castle Ward. The link really, and the kind of better news is, and it goes back to what Andy was saying about things like outpatients, is the Royal is our most congested site, both in terms of the numbers of services provided there, the numbers of visitors therefore, the numbers of patients. We're going to decongest it by the creation of the treatment centre at the Glenfield Hospital. So the Glenfield Hospital essentially grows by about a third, and a lot of the high volume services, you know, outpatients and some of the simpler elective procedures that we carry out currently at the Royal will shift up to the Glenfield, where there will be 2 more extra multi-storey car parks created. So that will decongest the Royal, put more traffic onto the Glenfield, but we're also putting up extra car parking space there. So hopefully that problem will alleviate. Just bringing it totally full circle, Sarah mentioned that part of the NHS plan is to reduce the numbers of outpatients we see. That isn't to save cash, it's because actually the outpatient model that is currently in operation across the NHS was dreamt up in 1948 and it hasn't changed a bit since. So it's long past its sell-by date, even down to we'll routinely do hip and knee operations and then bring the patient back 6 months later just to go, yep, you look all right, on your way. And that makes no sense whatsoever, for all the reasons Andy's set out. So our ambition is to make that work disappear almost in its entirety and only do follow-ups where most of our volume work is, if there's a therapeutic and patient value to it. If there isn't, we shouldn't be doing it just because it's custom and practice. So all that will help, hopefully.
I know there's a lot of problems as well in areas because of the amount of developments that are going on in areas that's creating large amounts of residents, which again, it makes it very, very difficult. And I know that the Leicester Royal Infirmary was built in another era, where there wasn't so many cars and things like that, and being in the centre like that, obviously it does create massive problems. So, you know, it's something that, it's, although we have a little grumble, it's not really because it was in the centre and not built for the amount of traffic that it's receiving now. But thank you for that about the general, the Glenfield, and yeah, thank you.
Patrick.
Yeah, it's just a point of information. I take councillors' points about that quality is a generic issue that affects the whole of the city and the county. But I would specifically, when you're talking about severe pinch points, I would invite anybody to walk with me. I no longer, they changed the boundaries and it's no longer in Castle Ward, but I had the pleasure for 12 years of representing Walnut Street and Havelock Street. And if anybody wants to take a walk down Walnut Street, you can write your name in the windowsills. And that's not because of the residents, it's because that is the sheer amount of particulates that are there. It's not all to do with the hospital, but clearly anything that can be done to reduce that and is both better for the people who live in those areas, and it's also better for those who work and visit and reside in the hospital. But I really would say, whilst I take the point that it's a generic issue, there really is a very specific problem that is caused at that location.
Thanks for that, Patrick. Yeah, we've actually, at our local health overview scrutiny committee, we've had already started having reports about air quality, more from a public health point of view, but generically we are looking a bit more at it. And in fact, just because lots of people are talking about it, I will remind people, if I haven't said it before, my own village is the 4th worst in the East Midlands for air quality. I checked, actually, nothing to do with the agenda today, but in fact I did check yesterday, just because we've got a live feed we can have from the air quality monitor, and we hit over 250 micrograms per cubic metre last Monday. Now, 200 in a day is when they start, red signals start applying, so this was 250. Clearly that's a country road through a small village in South Leicestershire. There are clearly problems.
Thank you. I'd just like to touch on Sarah's point about technology and the use of technology. At Healthwatch Rutland last year, we engaged with people from learning disability groups and also people with dementia. And the clear message that we got through is that the technology is not available to them. They don't like it, they don't want to use it, or they can't use it. So I just want to point out that there are digitally excluded groups that need consideration. My second point is that I can't remember the percentages, but I remember being at a meeting somewhere where they said that there has to be a percentage of appointments available to be booked online. But it doesn't specify who those appointments are to see. So, as with your good self, I have checked on my surgery, and I checked a few weeks ago, and at the beginning of December, and I found I could see umpteen nursing assistants to have a medical, sort of blood test or blood pressure. I couldn't see a GP until the middle of January. If I try to book on the telephone, I can't get through. If I go down to my surgery, if I actually get in my car and add to the pollution by travelling 5 miles to my surgery, I have to stand in a queue to speak to a receptionist to get an appointment, and I am triaged in front of all the other people standing in the queue. Now, this isn't just me. I'm not just raising my problem. These are issues that have been highlighted to us. People don't want to stand there. Women don't want to stand there and try to book a smear or something and have to give details of their last menstrual cycle, etc. In public, it's just not on. Yes.
You need to press your button, Andy.
All I can say is we're listening, we've heard it. I don't think what we're doing enough at the moment will fix it, so we're going to do more in different ways. But it comes back to the same point for me, which is we need a different type of conversation, because I think we're trying to solve this at the margins when in fact it's fundamentally wrong. And so we've got to kind of start over, actually. We're not going to make this better by doing a little bit differently. We've got to do things completely differently. The digital exclusion point's really good. It's got to be part of an offer, not the only offer. But there are also things that technology can help with behind the scenes that everybody can benefit from. So, but you're absolutely right. We're sensitive to that too, I think, yeah. Gail.
Thank you very much. I'd like to support what Janet's just said. I've heard that example, not Janet's, others, about a Rutland practice before. And also that you can't get through on the phone. And the reason you can't get through on the phone is because the receptionist who would answer the phone are actually dealing with this long queue of people. So it becomes a self-perpetuating problem. Whereas in my surgery, which is obviously not the same one as this one that has all these problems, I ring up and I can get an appointment more or less straight away, which is great for me. Now, whether it's because I'm articulate enough to actually articulate the problem that I've got, that they recognise I wouldn't be ringing if I didn't really need an appointment or not, I couldn't say. But I suspect there may be an element of that as well. Because I know that my other people in the village I live in, including my own sister, grumble they can't get an appointment. Now, my sister doesn't ring up for one because it's a real faff for her to go to the doctor, as there's no bus and she doesn't drive, so she has to get someone to take her. So I suspect that her more diffident manner enables her to be fobbed off, whereas my more assertive manner doesn't. So I think there's an element of that we need to consider. But also, I think there really needs to be a much clearer, I'll use the word contract, although I don't mean that literally, between the GP, surgery and the patients. And that patients need to be very clear about what they can and can't expect. Because as a ward counsellor, I had my ear bent recently by a patient who couldn't get an appointment within 2 weeks, and it really wasn't acceptable. She needed one that week. It turned out she wanted to see her named doctor. And fine, you know, we all have that right, but we need to understand, you know, people go on holiday, doctors go on holiday, you know, have other problems, they're ill themselves. So there are some times when we can't have what we expect to have, and that's our responsibility as counsellors to help explain this, but we can't explain it without an agreement of what it is in the first place. Yeah. Exactly. And one final point I'd like to make. I very much welcome the fact you're talking to our council leaders, but can you please remember that what we do as councillors and what we provide for our public is very different between the three of us. Leicestershire has a set of standards, Rutland has a set of standards, Leicester City does. Some of them will be in common, a lot of them won't be. And while I'm speaking, by the way, this is completely inaccessible to me. I can't read it because of the way it's been designed. And that's my point about accessibility when you're trying to communicate with people. Thank you. That's just a side.
Maggie.
I'll be very succinct because I'm conscious of time and everything, and I don't expect an answer back, but it's just a comment really that when you're doing your step change or pressing this reset button, can you incorporate your ability to utilise Section 106 monies? Because I think that goes back to David's point about capacity. We've had an awful lot of development in a lot of our areas. Surgeries can't cope. The 106 money is there, but your ability to utilise it and get things moving delays things and is causing a lot of the problems we're experiencing in our surgeries.
Sorry, just following on from Maggie's point, because I think 106 is really important, but actually the other part of that is the temporary impact it has on permanent communities. So obviously, my patch is Braunston, we've got Lubbersthorpe, huge development. The GP is picking up the spare people that are moving to Lubbocksthorpe from this community, as well as the current community until the new services are built. So there is a transitional issue as well, and whether or not that could be picked up, because I know the significant pressure on this surgery is because they're serving a much larger population than they were ever expected to. Yeah.
Okay, thank you very much. The one word I've heard that keeps cropping up, and it's certainly one I wrote down when you gave the slide over, when Sarah did the slide, is consistency. And I think that sounds, and I've heard, I mean, okay, it took me until, what it was, 20th of February to book an appointment. I was speaking to one of my colleagues over lunch this week, and she could get an appointment within 2 days. And that's a totally different area of the county. So it's that bit, isn't it? So,
I have to pick up children and I have to leave here in order to pick them up. So not working through and taking... Do you mean through the agenda or just call it there? Oh, love to work through the agenda, but can't take a break for eating or anything like that.
Want people to pass out through lack of sustenance. But yeah. And if we, I mean, with a bit of luck, we may, you never know, about 1:30 we might be clear. Yeah, call him, yeah. Gamete and embryo cryopreservation. So welcome.
Thank you, Chair. I'm mindful of the time, so I might just pick up 1 or 2 salient points and then open it up to questions, if that's okay, with members around the table. So hopefully people have had the opportunity to read the paper and some of the appendices behind there. You will gather that there is a varying approach to gamete and embryo cryopreservation across the East Midlands, whereby some CCGs have got policies and others don't. And even when CCGs do have policies, there are differences between who's included and who's excluded. So essentially the purpose of the proposed policy change that we've got here in front of you today is to be able to have a consistent policy across the whole of the East Midlands, which currently doesn't exist at the moment. And essentially what that aims to do is really provide provide some consistency, so that we've got patients who aren't necessarily just cancer patients who are undergoing treatment, who would be where this policy would apply to, who would be at risk of permanent infertility, but also to other groups as well. And some of those that we've included, such as the transgender patients who are undergoing treatment for gender reassignment. So it's useful and helpful, hopefully, to be able to articulate that about that consistency and that fairness for all. The second point that I wish to make is around, we want to start a 4-week consultation process on the 3rd of February on behalf of all of the East Midlands CCGs to essentially assess the impact of the policy by asking for people's views. We've already engaged with colleagues from Healthwatch. Unfortunately, Michael had left the room, and both Healthwatches, and also the LGBT Centre around the wording of the policy, etc. And we're taking some of those comments on board as part of the consultation process. And we're meeting with the LGBT Centre next week, and in particular with their transgender support group, to hear their thoughts. And in addition to that, our comms and engagement plan will also be linking in with the gender identity clinic as well as the fertility clinics as well. And in particular, we'll be looking at further ways where we can have more of a targeted approach with all of our communities. People will have the opportunity to comment via our online survey or paper copies, etc. And the outputs of the consultation and its findings will be presented to a joint committee across the East Midlands, which represents 16 CCGs, who will be able to make a final decision on the policy. So those were the key headlines that I wanted to outline in the order of time that you have, and we'll open it up to questions, and myself and Dr. Tim Daniel, who's a public health consultant, will hopefully be able to respond.
Thanks very much, Kat. That's good.
Just quickly, one I was just curious why it wasn't, we're going for the East Midlands policy, but why it isn't a national policy anyway, because of postcode lottery, etc., etc. So I was just curious about that. And the other question was the reason for cut-off ages, 55 for men, 43 for ladies. I just, logic behind that, really. Thank you.
If I pick up the first point and Dr. Daniel's second, so we understand from a regional perspective it makes sense for this to happen from a national perspective, and I think the attempts are to try to bring all of the positions nationally to more of a consensus, and it's easier to do that if you approach it from a regional perspective first, because there will be natural differences, but where we can get some commonality on that national picture, we will endeavour to do so.
Yes, just on the second point about the age limits, they're largely related to the efficacy of the treatment. So, because of the efficacy of treatment in terms of actual fertilisation in women, there is a reduction in that as time goes on. So we use 42, which is currently supported by NICE for the IVF policy. So it's duplicating that in terms of the cryotherapy policy as well. The age limit for men at 55, there is some, perhaps not quite such robust evidence that beyond that age group, the chances of being able to father a child and the quality of the sperm and the ability to reduce the risk of congenital disorders, that is a useful threshold for us to use. So what we're trying to do is maximise the quality so that we can ensure that we use this service effectively.
I have exactly the same thought. I think for me it's actually not necessarily the extraction of the egg; it's the planting the egg back in. Sort of age query I have is obviously, I understand the 42-year limit in terms of taking, as our eggs degrade over time, but the stimulation treatment, is there a particular reason why an egg that is frozen at a particular point in time is not as viable in a woman of that age? Is that I was just curious, really.
Actually, there's some quite good data from IVF clinics, because they use a combination of both fresh embryos and they also use frozen embryos. First thing to say is that frozen embryos actually give similar results to fresh embryos. The second thing to say is that there is quite a clear pattern you can see in terms of both fresh and for frozen. It's exactly the same, dependent on the age at which it was frozen, as to how likely it is when you re-implant it that it will give you a successful pregnancy.
Just I suppose that for me it's the point at which the embryo is replanted rather than the point at which it was frozen. I was querying, really. Suppose, physically, I'm cut off. I'm 43. So, I know that, physically having a baby would be more tricky as I get older. I get that. However, the ability for me to have a baby would be different from the egg itself. Sorry, that was really bizarre way of saying it, but it's for me in my head, it's about using an egg or a donor egg. Let's not freeze them. Let's use a donor egg. It's the query about is it less successful in a woman that's 43 and above? Because we can obviously still physically have a child. It's the egg obviously that degrades over time. That was
right,
the query.
So it is effectively. Yes, there is a reduction as you go through time, but I think the other important thing that this is the cryopreservation policy. Okay, so this does not cover necessarily contingent policies as to actual the fertility treatment that you receive at that point.
That was for me to try and get my understanding of.
Right. Sure. Okay.
Yes, I'd like to ask Ket when he actually consulted Health Watch Rutland. I've only been the chair for a year, and I don't recall any conversations with you.
Okay, apologies if that's the case. So Joe Ryder, who's a member of our comms and engagement team, has liaised with all of the health watches around the sharing of the policy and the comms and engagement plan, and our approach that we intend to use and what the feedback is from the respective organisations. If that hasn't necessarily filtered all the way through, which is what you're alluding to, then we'll make sure we come back to you with that.
Could I just ask how soon that will be?
We can do that immediately following this meeting.
Yeah, okay, thank you.
Yeah.
And I'd like to take it just a little bit step further, because sometimes I get the feeling that Rutland is a little bit of a sore on the side of the Leicester City and Leicestershire, and we're not. Yeah. We are trying to work with everybody, so please engage with us.
Yeah. No, definitely.
Yeah, I mean, it's obviously a fascinating scientific area anyway. My own experience is not exactly what you have on this paper, but 40 years ago I used to do a huge amount of work, scientific work, published a lot about cryopreservation of bacteria. I remember just how complicated even that little bit was. So now having lots of cells all clustered together as an embryo, wow, most really has a, I'm very impressed, so it's good stuff.
Well, we've got 500 births a year at Leicester General, so the more the merrier.
Oh, I'm too old now. I've said I'm too old. We'll move on from that. Thank you very much, Kat and Tim. That was very helpful. And our penultimate question, well, our final main item, it's vanished. Was it? Oh, there it is, yes. Relates to transforming mental health services. And the report in our pack is on pages 89 to 98. And we have got John Edwards here. Thank you very much, John. Associate Director for Transformation, Leicestershire Partnership NHS Trust. I'll leave you to explain it. Have you got some slides? No? Oh.
Do you want me to get them up?
Right.
They're in the pack.
Yeah. I saw them in the pack, but of course. Oh, I see. Yes, true. There's this very complicated one. So while he does that, if you want to introduce...
Yes, hopefully you've had an opportunity to read the succinct information that I provided. I've been to a few different forums, so this probably isn't the first time you've heard me talk about this. I've been to the all-members meeting in the county in Rutland, and I've also been to the City Health and Overview Scrutiny Committee as well. So I apologise if it's a bit repetitive, but here we go. But hopefully, like, reinforcement's good as well, isn't it? So. Okay, so we'll work without the slides. So I'll point to the random screen. Okay, so. The paper and the slides are the paper offers a little bit more detail than the slides, but broadly they're the same anyway. So I'll talk you through the slides just because. Oh, here we go. Is there a pointer? Oh, sorry. Okay. I recognise you've been in this room for a very long time, so I will try and make this succinct for you. Yes, okay, right. Well, I'll be even quicker then. Right. So, context, which is pretty familiar to you, which is... oh, dear, sorry. We have been and continue to be a very challenged system in terms of mental health. We've struggled, and particularly talking about adult and older people's mental health today, just to put that context, so less of the children's. We know from... as the main provider of LP in form of LPT of mental health, and through other providers around mental health, that we struggle. We have had various CQC reports that would suggest that we're far from where we need to be. And there's a number of measures that also reinforce that it is an extremely challenged system. And in recognition of that, a couple of years ago, we set off on really radically rethinking how we do services, which this is largely talking about. We've got to a point in it that we're really accelerating what changes we want to make, and that's largely what I'm talking to you about today. Some of the things that have been improving, sorry, I'll try and read off here rather than lean backwards. I've highlighted a few areas. There's more there, but you know, in terms of we've got old environments, our inpatient unit's a bit struggling. We've done a lot of improvements to it. It's starting to get to the boundaries of what you can do with the environments that we've got. But we do have further developments that we can make to try to reduce over the next few years the dormitory accommodation to go into single accommodation, which is quite important, which will modernise it further. Workforce, as you probably appreciate across the country, workforce is quite a challenge in terms of mental health staff. And so alongside the national direction, really, we've been introducing different roles. I guess we call non-traditional roles. Some of extremely exciting, like our first cohort of peer support workers, as people with lived experience that we employ. Although very early days, as I say, they started in January, the evidence base around it would suggest that that could make a significant difference with people's recovery. So I think there's a really progressive approach within the region. In terms of our performance in general, over the last few months we've made significant improvements with our inpatient beds. In particular, we had a significant amount of people in out-of-area accommodation. As of summer, we had a lot of people, up to around 40 people out of area, which is a big spike for us even, but nevertheless a terrible situation. There's a national trajectory to in effect get to a place where there's no inappropriate out-of-area placements by the end of March 2021. And at the moment, we've turned that around so that we're below that trajectory. We've still got some people out of area, and that's still not good enough. But we are below where we even set ourselves on that trajectory. So it's been quite a remarkable turnaround. But it's difficult to sustain. And so this is where, in part, there's not that this is geared totally for inpatient-related stuff, but just in general, how all of this sort of comes together. There is a complicated diagram behind me. And I recognise that you're not experts of mental health probably services, and this probably doesn't mean a great deal to you. I guess what this is trying to, if we go with what conceptually this is trying to show you, it's that we have not really had a systematic way that we've joined up our different bits of services up to this point. And by going through the co-design that we've been going through, bringing together service users, carers, staff, other stakeholders, really rethinking how all the services work. The benefit of that is to actually have a complete idea of how the system should and will work in the future. And I'll highlight a few of those areas that hopefully is a bit more tangible for you to understand. But it's just to get the idea that this starts to become a complete picture, that we should see people in effect, which is what's sort of represented here, being much better support for people, as in actually being able to access support directly themselves, not having to go through complicated arrangements with GPs or not knowing where to go. So having direct access to mental health services in a way that they haven't had previously. Really supporting primary care so far more mental health support can be delivered around the new primary care networks, where really core mental health services starts to become established rather than in specialist, sort of almost siloed specialist services. And then a much more integrated specialist service that actually takes away the internal boundaries that's arisen between services, and has a much more targeted offer, and then a reduced inpatient ultimately, because the demand should be moving much more to community, and certainly in terms of people going out of area. So if that sort of brought it in, and I can answer questions if you've got specific ones. So just to give a sense of pace, we're setting out. So in effect, after what we've been doing, which is largely design work over the last couple of years and some changes, but largely design, we're now reframing. That was under the auspices of all age transformation, which people have heard me talk about, and we're reframing it to really give it impetus that this is putting things into practice now. And so we've framed this against something called Step Up to Great Mental Health, which links into the wider LPT transformation agenda. But in effect, what this means is that we are looking to make a lot of changes quite quickly. But over the next few years, we're looking to in effect lead up to that model that I was trying to show up above. So the things just to connect you with that 2020 will bring is for the first time, people will be able to access crisis services directly, self-refer themselves. That should be up and running in July. It's complicated, it would be fair to say, lots of things that we're working through, but it will be open in July. If people attend the emergency department, which we want to reduce the number of people that are attending the emergency department, and we believe by having direct access to a crisis service, people will have an option other than emergency department, or some people will. But if they do end up in the emergency department, what's referred to Core 24, which actually relates to a set of standards, but it's a sort of mental health liaison service that we've enhanced around there. Then there will be mental health assessment and expertise brought to a person within an hour around the emergency department, which is a lot more responsive. And at the moment, some of the longer waits in the emergency department have been relating to mental health. So this should significantly reduce some of that waiting that's happening there. And by connecting it and seeing it as all part of one bit of system, by the way, that it's also easier then to move into community support, particularly in terms of crisis home treatment. That is beyond just the emergency department. That is also about having better support for the wards as well, so people in physical health wards. And there are targets around that, which I believe is 24 hours, but it should be a lot more responsive. In the community, our assessment of crisis will also be a lot quicker. At the moment, we have two differentiated targets of 4 hours and 24 hours. There will be one target, which is 4 hours, and that's what we're gearing up to. So it'll be a lot quicker. So not only will people be able to self-refer, and with the ethos that we're taking through in the central access point, which was on that diagram, which is being helpful. So this isn't about trying to reject people and say, actually, you're not for us, you don't meet the criteria. It's helping people, not all to our service, not all into secondary mental health services, etc., but as a principle to actually help people who have a need, irrespective of whether that requires a full crisis response. In terms of discharge, we've already started having a more of a facilitated discharge processes from our wards, which in part is helping with that improved situation with people being placed out of area. That will carry on being iterated, but it allows us to draw more people into, in fact, community services quicker from the current mental health inpatient services. Other than that, part of the integration of community services, specialist community services, is tackling what we have long waits for certain treatments, particularly psychological therapies, and we're having to needing to. And have an exciting plan to redesign a lot of our treatment offer, in particular around our psychological services, which means that much more is done locally within community teams, and we're bringing best practice psychological therapies more to bear as well. One of those pathways that we'll be moving quite quickly on but will take time to fully embed, and probably before we see the full impact, it will be probably a couple of years, is around individuals with a diagnosis of personality disorder, which is a group of individuals that are largely end up getting drawn into the inpatient system, or at least people with higher risk factors, which the evidence would suggest is counterproductive for their health. So by trying to actually support people in a much more coherent way within community, we will or the evidence and other services experience would be that we will significantly impact on not only that sort of the inpatient stays in general, but obviously providing a better treatment offer for them. Yeah. So in terms of the sort of next steps, other than continuing with the stuff we're getting on with at the moment and delivering, we're working up with Healthwatch and partners within CCGs a strategy for how we're engaging around that complicated diagram, making it easier for people to digest. So people have got an oversight of where we're going in broad terms. There's going to be lots of specific changes that we will be taking as a consequence of delivering it, and each one of those will be working through a kind of proportional engagement plan, which may involve consultation as and when required, and we'll be working through that systematically with partners. We're hoping, and Healthwatch are quite up for supporting us in that wider engagement work and really drawing in the many different groups of interested parties that often struggle to contribute to their views to things. We're also committing to ongoing co-design. Co-design is quite hard, is our experience, and it has been through this process, but massively powerful and useful. And so our commitment is that as we're moving these designs into practice, that co-design is still at the heart of it, partly because it helps us keep the shape of what we're trying to do here and the benefits that we want to see from it. So I guess it's questions.
Thank you very much. Maggie.
Thank you. It's about out of area placements, which I think really you touched on, John, and you more or less covered, because it's obviously stressful for patients and their families if they've got to go out of the area. And it's really what is the possibility of bringing that service in-house? I suppose it depends on capital investment and value for money. So it was just a conversation around that, really.
So when you're thinking of out-of-area placements, it's helpful to think about, let's go with two different types. It's more than that, but you've got, in effect, people that would otherwise have gone into our acute inpatient services, which are based at the Bradgate unit, but because of capacity issues, they couldn't be accommodated, and they end up being placed in other out-of-area placements. By improving flow, they come back. So it doesn't require new facilities. It doesn't require, in effect, capital. There was other capital issues, but it doesn't require specific capital around that. The other type of individuals that you might be referring to are people that are placed for services that aren't provided locally. So they're referred to as like almost specialist placements and are done on a spot purchase type basis. The personality disorder pathway that I was referring to is our biggest impact point in that. So we have at the moment out of, and this is a very broad categorisation, so don't hold the numbers, but because it has a habit of being a bit binary when it's not, people are complicated, but of the people that are placed out of area, the majority, in terms of these specialist placements, the majority that are particularly related to adult mental health, again, I'll nuance everything, I'm afraid, but relates to people with a primary diagnosis of personality disorder. The pathway and the approach that we're moving to really emphasises delivering vast majority of support for people in the community setting, which will end up meaning that we will actually titrate down the amount of people that need a specialist placement and therefore reduce that without having to replace it with another type of inpatient facility. The services we change in community, it might not eradicate the need for specialist inpatient facilities, and our longer term view, as we understand more about how many people you actually do need to place out in those type of placements, is it relates to what we do with with rehabilitation. We have a number of beds in the moment locally associated with something called mental health rehabilitation. And we don't provide any community offer at the moment for people for particularly that type of mental health rehabilitation. And one of the things that we're looking to introduce this year is about a community rehabilitation offer. subject to a little bit of money that we're doing business cases around at the moment to pump prime. But that will allow us to, in effect, to reduce some of the bed base that we've got at the moment, and will allow us potentially at some point, if we still need a specialist, a different type of specialist beds, to repurpose that facility at a later point. So it's trying to connect the dots all in the direction of moving people away from out of area. So there's a broad plan, but some of it has to be discovered when we understand the extent that community services will take away that need for inpatient facilities. And although we've made some estimations, until it's happening, it's very difficult to be absolutely confident. But that's broadly how it will shape up, I think.
I think the only thing that worries me is when it goes to the community is the capacity within the community, because as we've heard through, the previous presentations, it's that capacity issue all the time, and that's what would really worry me. But thank you for your...
If I may respond to that. So the changes within community services is about, part of it's integrating different bits of system together, which will increase some of the capacity that we're talking about. So it's like repurposing some of our existing resource. And some is investment, which there is a national investment in mental health. So a lot of that will be targeted towards community facilities, not only specialist mental health community, but also that primary care orientated one. Because it's all, if you imagine it, it's like a flow, isn't it? So we need to be able to be moving people out of specialist mental health services quicker as well. And that relies on primary care being suitable to be able to support that. So there are new monies coming in. You know, it's always a challenge, but there is, yeah.
Thanks. Yes.
Thank you. So whilst I guess I very much support the two things. So the first, to reduce how many people we have placed out of area, and all the work that's happening and will be happening around that. And I also support the move from, of course, from what seems a bit, it just seems so outdated to have dormitory accommodation in acute mental health. It seems very outdated, and that we do need privacy. Any of us at that time. I guess as we do that, my reservation, and it is grave, is about a reduction in beds, because clearly if we're moving from a dorm where we can have an awful lot of people to single bed units, then that there is a massive risk in a reduction of people we're able to accommodate in area, a devastating time for them and everyone around them.
Agreed. So at the moment we've set out a 3-year plan for how we move dormitories. We're between a rock and a hard place in part. We're capital poor in the system, which is challenging, but we're also limited on the physical environments that we've got. Unfortunately, the Bradgate unit was never really designed for mental health services, and it was repurposed a long time back. But some people might have memories there. But I mean, so that dormitory stuff is a reality that we're in. The first year of that has very minimal impact on bed numbers, because there is one smidgen of opportunity to increase beds through a little bit of an extension in a little bit of corner of a little bit of space, and that's what we'll be doing first. So the initial reduction so we're trying to do it phased on a very similar basis. Your anxieties are well reflected in our anxieties, because we're committed to not leading to increasing out of area placements, and we want the system to function. So the first year is minimal impact. Thereafter, bed reduction may lead to that, and one of our challenges is about how we resolve that, which we'll come back at a later point with more clarity on as we've got more clarity. Part of it will be about how do we achieve the flow that we need to do, which might allow us to be able to contain within the beds we've got. In the end, so I mean, it'd be better to talk about that properly and fully with all the detail around it, I would say, so that you can have a proper review of that, if you see what I mean.
Yes, thank you for your, for being candid about that, and I think we definitely want to see, I mean, I definitely want to see if we're serious about reducing mental health beds. I'm sure everybody in the room and wider would want to see that. I guess you know, we're talking about reducing beds, but actually and flow and improving flow, and that's great. But also, that's where we are now, and you know, if we're rebuilding parts of a hospital, we need to be projecting into the future. And where I'm at, you know, it seems short-sighted if we are assuming, you know, a standstill in the amount of acute mental health beds that we will need, and especially given that we know resilience is challenged when people are moved out of area, but also resilience is challenged, you know, certainly in the city, as austerity bites and people's lives become more chaotic and harder to manage. Of course, it's not just those people who experience acute mental health, but the lack of resilience is growing. Thank you. And the population is also growing. Thank you. Sorry.
So, agreed, right? So there's a few things to factor in here. One is that this is concurrent to the development of a case for rebuilding our mental health services, in inpatient and mental health services. So the intent is to have a purpose bill of the right nature, mental health services, and it's far more complicated because we've got age in this as well, and an ageing population. Different hospital in that sense, but you know, I don't know if I want to go there. I suspect I don't. No, nothing to do with me. That's the best problem. Right. So, but in terms of mental health, yeah, we are. But it's a sizable capital thing, so we're very reliant on national. There's been a lot of signalling that might become available, particularly in recognition that mental health services has historically been underfunded, and particularly in its capital as well. So. But to reassure, even with that context, there are other sites that we're benchmarked with that can occupy less beds as well and cope and not have out of areas as well. So both of those are helpful, if you see what I mean. So we can have confidence that we should be able to do this, to work through this complication that we're all dealing with. Trying to get the privacy and dignity, trying to do the right environments, trying to get the flow right, and trying to develop the state for the future, and not lead to the negative consequences of out of area flows and all of the things, because we're all bought into the same objective there.
Yes, thanks for that, Amanda.
Okay, so I have a few things. I've managed a team of peer support workers in Nottingham some time ago, and one of the things that we found with lived experience is it was great, but we had to be very careful that we also didn't become a service for the lived experience workers as well, and that did drop in and out sometimes, where the lived experience workers, you could see their own mental health was being affected by supporting others with through their conditions, and it became sometimes quite tricky to work that through. I suppose the other thing is the bite back in terms of what work have we been doing with trying to prevent readmission into hospital. So again, I was involved in a home service that actually exited people from the Braggett unit into accommodation. And actually, it was part funded by NHS, part funded by Leicester City Council and the authorities in terms of providing ongoing intensive housing management services. That's all gone. And it's how do we, as from a social care and health and mental health services, expand the services directly available to users to keep people safe in community. So I work for a housing association that supports mental health clients and their mental health. We have, I would probably say, we go up and down with some of our tenants, and part of that is about how their service packages have changed over time, and austerity is certainly bitten for them, because not only did they have financial pressures, we've got people being shifted onto universal credit and they shouldn't be, and that has a massive impact on them, but also their support has also reduced to maybe 1 hour of floating, whereas 3 years ago they might have had 10 hours a week, and it's quite a different set of support services. So how do we manage that challenge? And finally, I want to say thank you for looking at the impact in emergency in the A&E. My father-in-law had post-op delirium and was in A&E for 13 hours with post-op delirium, with my husband trying to manage him for 13 hours. It's really hard to do, and anything you can do to support A&E to ensure those people get the services as quickly as possible would be yes, thank you.
Okay. Thank you. Yeah, no, it's yes. I think that yes. I mean, A&E is one hot area. There's lots of places that people present that aren't mental health services, and it is a lot better than it has been. But as we see, there's a lot to do. In terms of peer support workers, we've been really conscious of how to do this in the safest way for them and services, and it is new to us, and it will be work in progress, and I'm sure we will make some errors along the way. We've done a lot of learning from some sites that seem to establish this really well now, particularly in Cambridge actually, but a few other sites as well. And so we've tried to put all of the kind of infrastructure that you would expect to see, a lot of paying attention to, trying to keep them well, but also preparing the team they're going into well, because part of this is about integration of staff, because they're not different or unique. They need to work as a cohesive. So I think we're paying attention to it, but I recognise the risk, and it may be that some of what you're describing comes to pass as well. And certainly previous experience when we've dallied at it, as it were, had a little go, has ended up with people largely going off sick and not aiming to work. So we need to be really careful of that. The second point you work, and I'm now working back my brain. Bear with me. So what was this? Oh yes, sorry, thank you. Yes, quite a significant one. Yeah, that's right. It's constant work in progress. Is the honest answer. We've got pretty good relationships with our housing providers, particularly around our inpatient services, and are constantly helping them think about their planning and also evolving how we relate to them. As always, it is one system in its complicated form, and changes to one bit of it does affect other bits and all the jazz. I guess that what we are trying to do as a system, which you might have heard about earlier, but also very specifically here, is about how you maximise the social assets around people and try to maximise on whatever is available, because you can only work with the reality that there is. And where we've been perhaps maybe in some instances we've tried to take over people's lives a bit in health services, and try and do everything for people and then run out of capacity, and in some we've left them to our detriment, a bit of both. We're wiring in as much as possible, and I guess I'm pointing at nothing there, so apologies. The diagram that isn't there, the primary care plus, which is the sliver around PCN, is quite important to us, because that's obviously there's a lot of investment in social prescribing. It's going to take time before that's really good, isn't it? Let's be honest. But wiring into the ethos and the intent and how that evolves, and we're trying to do our own thing as well, because it needs to work for our people. Because what we find is this social asset doesn't actually accept the person that we're talking about, particularly because a lot of people with mental health drink alcohol and have substance misuse, and that is a significant exclusion of housing as well as everything else. So it's trying to pay attention to that and draw what we can around people whilst doing some specific things. And when we're talking about community rehab, part of what we'll be trying to work through is perhaps having targeted housing solutions that really pay attention to the people we're talking about and have really good solutions for people with dual diagnosis, so people with drug and alcohol abuse, because people are socially isolated in so many ways, aren't they?
Thank you for that. And Janet?
I've got 2 points actually. The first one is from the help for patients that are in acute hospitals but suffering mental health difficulties, so they've got a comorbidity there. As a retired registered nurse who has sat with patients that have been prepared to wanting to actually end it all and not being able to get any help, I really applaud that initiative. because I would be spending days trying to get people psychological support and just could not. So well done on that. My second question really is the self-referral system that you're having. Is that just for existing patients, the patients that are known to you, or anybody in the street that suddenly decides that, you know, the end is nigh?
The latter. So not necessarily hoping too many people are seeing the end as nigh, but it is for anybody. So it's quite an endeavour, but it's so important because people. It's a challenge anyway, in which way I can go into more detail. But it's for everybody. And just to pick up on the previous point about the physical health. What I've described around what was framed as Core 24, but that liaison service will help a lot. Also, what should be helping is changes to the IAP, so I can't even remember what IAP is for myself now. Sorry, apologies. But the psychological services that's available are largely around primary care or in between primary care and secondary care. They are doing and will be doing much more work with people with long-term conditions, and so they're again trying to be far more proactive in supporting people who might lead up to either adjustment issues with what the illnesses they've got, or the fact that a lot of people with long-term conditions, like a lot of proportion, will also have a mental health issue of one kind or another. So there's some proactive work, or some work that'll be around there as well. And the other thing that we were airing in the Health and Wellbeing Forum just yesterday, a workshop which was targeted as a county, was targeted towards mental health, was around being much more proactive in our promotion of the 5 ways to wellbeing as well, and trying to encourage a far greater awareness. It's been much better anyway in general terms, but that there are things that people can do in general terms that will increase the resilience that we know we also need to do.
I don't want you to go into the detail now because I think we're all really wilting, but I'd be really, really grateful if you could send me some more detail about the self-referral service, because I have a fear. I'd like to know the pathway that the patient would go along in that, and I have a fear that it might overload the services.
So I'll try and provide some more information. I'm trying to think of the right thing to send you, which I'll have a bit more thought about. But just to in broad terms to reassure you, I hope, is that we've modelled on other services that have gone to having direct referrals. It hasn't overwhelmed systems as much as you might imagine, and that's the learned experience from other sites. Though obviously there will be a much higher call volume in particular to a system, and we've modelled on a reasonably high amount of calls expected, and effectively then built the triaging in the system accordingly. So, but I will try and share you something.
Thank you very much, John. Thank you very much indeed. Our final paper. Thank you very much for getting through it quick as we could. There is one final point, although it does say basically date of next meeting, which as Patrick Kittrick said was 18th of March. There is a problem in that on that day we've got the agenda item for the winter pressures item, which is this time of year is what we always go through, which is obviously important. But it actually clashes with the UHL's A&E delivery board at 10 o'clock in the morning. So the suggestion is that we might move this meeting a bit later in the day. No good for you, is it?
It's cost me £70 to be here as it is in order to cover the childcare.
So how do you
that
ever
I
go
need.
to afternoon meetings? You don't?
We don't have afternoon meetings. They start at 5:30.
Because all hours normally are.
I understand that. I work and I've got small children. The juggle is real,
yeah.
But I'm sure I'm not alone in that amongst the working parents here, which might just be.
There are a few of us. There are a few of us that work still. But as I said, we have obviously a major problem because either we move the meeting entirely later. If we move the meeting, we could move the meeting a week later. But 10 o'clock is really difficult for most people here anyway. For me, I have to get here from miles away. And I know Rutland the same.
Could we perhaps have some consultation around dates with people who aren't here, because this is obviously not reflective of the entire group.
We also obviously
there's lots of different factors at play, but
sorry, we also need to look obviously at what's on the agenda anyway.
It's an expensive inconvenience as well.
Well, Patrick's suggestion was before we left that we actually do a email round and make some suggestions. Yeah.
Essential, or the whole thing's going to collapse.
Yeah,
especially when we're talking about things like maternity. My experience is much closer and more recent. Yeah. Yes, thank you.
Yeah, we'll work that one. Okay. Thank you very much. Thanks for coming.